Hello.
Jai Jai Shankara, Har Har Shankara. Lighting the lamp, our team will light the lamp now. I see Udari, O side में खड़े होकर सेपटर
गुरुर् ब्रह्मा गुरुर्विष्णु गुरुदेव महेश्वर गुरु साक्षात् परम ब्रह्म तस्मै श्री गुरवे नमः तस्मै श्री गुरवे नमः तस्मै श्री गुरवे नमः.
prayer. We request Dr. Sudeep Das, our medical director, to make a welcome address.
Good morning, everybody. Welcome. So after having I think, an interesting session yesterday, we were going on to, which was more basic, we were going on to more advanced stuff, more interesting stuff. So just a few, a little statistics about what it is like worldwide. So it's the second leading cause of blindness after cataract. It's probably the most common cause of irreversible blindness among people. So by about 2020, they said that they thought that about 76 million people suffer from primary open-angle glaucoma, and there's a worldwide incidence of about 2.2%. And that number is expected to reach around 112 million by 2040, which is an amazing number. And we have to understand that probably the vast majority of glaucoma patients are not diagnosed. About 85% are not diagnosed. And the direct costs of glaucoma include the medical bills, cost of medications, and transportation costs. And of course, loss, even more important than that is the amount in terms of loss in productivity and missed work. And Asians represent about 47% of those with glaucoma, and 1% of those with angle closure glaucoma. For various reasons, angle closure glaucoma is much more common in the Asian population. And glaucoma in India is the third leading cause of blindness, about 12 million. That accounts around 13% almost of the total blindness. And various population studies have shown an incidence of between 2 and 13%. And more than 75% of glaucoma are undiagnosed. That we see here also. People walking in, they've gone to various other hospitals, and we find that they have advanced glaucoma. Probably they're blind in one eye. That's when they decide to come to the hospital. And when you check, you find that they have a 0.9 cup in the other eye also. And they don't even know that they have glaucoma. And angle closure, primary angle closure glaucoma forms about half the number of glaucoma patients that we see in the hospital setting in India. And the dropout rate, this is the most interesting, that you diagnose glaucoma, you start treatment, but then about 50% of them will actually drop out. They will drop out of treatment, they won't even come back to the hospital after that. And the major reasons we think are lack of communication. They haven't understood the disease because they came they thought they had no problems, and nothing is actually changing. When they start using the drops, they would think that they will notice some difference. They're not noticing any difference at all. So they just drop out. And other factors are distance from the hospital. A lot of places are very far. They don't go for checkup. They can't get the medicines because a lot of medical stores will not keep glaucoma medications. And the cost of therapy. We know that a lot of these PGA analogs and all are extremely expensive. And main thing is open angle glaucoma, what symptoms do they have? Nothing. All of you have heard of Helen Keller. So she said she was blind from birth. But she had said that all the senses, sight must be the most delightful. She hadn't experienced sight, so she said it must be, because she herself didn't know what it was. And another saying by Sylvia Plath, who said, "I shut my eyes and the world drops dead." That is, you shut your eyes, you can't see anything. So basically, you're shut off from the world. I lift my eyes and all is born again. And this is something that will not happen to glaucoma patients. At one point of time, they'll wake up in the morning, they'll open the eyes, and they're not seeing anything ever again in their life. That's something which we have to remember. So this is something that Tamasoma Jyotirgamaya. So all of us talk about that in eye hospitals. A lot of us have that as a motto: from darkness lead me to light. But more important than that is Asatoma Sadgamaya, lead us from ignorance to knowledge. That is what is for us and for our patients. They have to understand the disease to be able to take treatment for that. If they don't understand that, so they will not do anything about it. Thank you.
My dear colleagues, hearty good morning to all of you. I see many new faces which have come up today. I guess they have all come from the medical colleges of Orissa. A hearty welcome to all the postgraduates. Can the postgraduate students please raise their hands? That's quite a number, which means we should have the quiz today somehow. Okay. And I congratulate the prayer song group which came up, and they sang such a beautiful song. And that second song which they sang was Modisha, My Orissa. Modisha, it was My Beautiful Orissa. I know that I come from a place called Tamil Nadu, where we have same feelings for our language. Yesterday there was a group which sang a song called Utkala Janani.
That is our anthem, state anthem.
Like state anthem, Utkala Janani. So I was reminded of our Tamil songs which infuse pride in our hearts. Like, for example, there are quite a few Tamil people here, which goes on, Yengal Valvum, Yengal Valamum, Mangada Tamil endru Sange Murangu. So that is the kind of regional feeling which we all have for our mother tongues. I really wanted to add a note of appreciation for that song group, which was our MLOP students. Just like how you are proud of your beautiful Orissa, Sankara Eye Hospital should be proud of its beautiful MLOP students in the future. You should read well, you should acquire knowledge, and we should sing. Like Modisha, we should say, my MLOP students. So you should reach that level of expertise, and that is possible with hard work, dedication, and hunger for knowledge. Hard work, dedication, and hunger for knowledge. That is one of the main reasons why we have invited all our optometrists and MLOP students for this event. The speakers who are going to talk after us, like Dr. Vasu, Dr. Devendra, and others, must keep in mind that in addition to postgraduate students and consultants in ophthalmology, we also have our paramedical team also. So take some time, extra time, to make sure that some concepts are simplified enough so that our audience understands that. So that is one point I would like to make for all the speakers who project. What we learned from the community glaucoma project. Welcome, Dr.
So, this pilot program was conducted by Sankara Eye Hospital in Ganjam district. In this is why the bigger global macro data points. So let's start with rapidly and irreversible. So as per WHO, Projection by 2040 around 112 million. It can go undiagnosed until very advanced stages. Therefore, its full magnitude is difficult to estimate, particularly in infrastructure. So coming to India, in India the estimate is around 2.3 to 4.7% incidence, with over 90% of the patients being unaware of the disease. And global estimates suggest that India accounts for 13% of all the glaucoma cases in the world. As per National Programme for Control of Blindness, the glaucoma has been recognized as a priority disease, but it suffers from the lack of clear objectives, strategies and actions. And various facility-based studies have shown that majority of the glaucoma patients in India, they are diagnosed at an advanced stage, and there are challenges in both detecting and treating the disease. So as we all know, glaucoma is usually caused by increase in intraocular pressure, which gradually damages the optic nerve. Age, sex, family history, health status and race, they all have been shown to be associated with risk of the disease. The high intraocular pressure is a major risk factor for loss of vision from glaucoma, and it is the only factor which can be modified. And we have the data from various clinical trials that shows us that effective control of the intraocular pressure, it reduces the risk of the optic nerve damage and it slows down the disease progression. So early diagnosis and treatment of glaucoma, it's critical for managing the intraocular pressure and prevention of severe loss of vision. So in a recent review situation done by Sanjam, he argued that in resource limited settings like India, the mass community screening or the glaucoma case finding, it is not feasible or practically possible, and he suggested that targeting opportunistic screening programs operated at various different levels of healthcare system will be more appropriate. So glaucoma test often starts with eye examination and measurements of visual acuity and intraocular pressure, followed by the referrals of the suspected cases for further assessment, which includes gonioscopy, fundus, optic nerve assessment and visual field charting to look for the glaucomatous changes. The problem is these tests are very challenging low resource settings, as the number of facilities which have glaucoma trained staff and the equipment is quite limited. And they tend to be located in large urban centers, therefore unable to reach to the majority of patients, especially rural population. Even the patient demand for services in such settings is also low due to the lack of awareness, inability to pay and the poor compliance. So the basic purpose of this pilot program was we integrated targeted glaucoma screening in community-based eye care service in the Ganjam district of the Odisha. We used routine program data to explore the enrollment and characteristics of the patients participating in screening program, the rate and the uptake of the glaucoma referrals, and the prevalence and the distribution of different types of glaucoma who were routinely screened. Hopefully this evidence will be useful to guide future efforts to control and prevent the glaucoma blindness in India, and specifically improve the glaucoma screening guidelines, training of healthcare personnel and the social behavior change communication campaigns. So this study was conducted in Ganjam district. We have around 3.5 million population. The district has approximately 124 public and 17 private healthcare facilities, but the ratio of doctors, nurses and the hospital bed to the population is relatively low. Our hospital is a 50-bedded private non-for-profit facility which provides service for all the segments of the population using sliding pricing with subsidized or free service for those who cannot pay. The hospital has already a community outreach eye care program and a glaucoma service too. However, prior to the pilot, the number of glaucoma patients presenting to the facility with glaucoma was, and they were primarily walk-ins or the referrals from other hospitals who could not provide the glaucoma assessment. So the pilot study was aimed to strengthen the existing care pathways and integrate glaucoma interventions at different levels of service delivery, including community-based interventions. So the Intervention included the development and integration of a tool to identify glaucoma patients at high risk of the vision loss. So this tool was integrated in the routine patient examination at the facilities at the base hospital and outreach camps. It included assessment of glaucoma history, IOP measurement using rebound tonometer, anterior chamber depth assessment, and optic disc assessment using non-mydriatic fundus camera. So as we focused primarily on the patient at risk of vision loss from glaucoma, our referral cutoff points were quite simplified, and these were the following. Number 1, cases with IOP more than 30, cases with vertical CD ratio more than 0.7, or IOP 22 to 30 with CDR 0.6 to 0.7, or IOP with 22 to 30 with shallow AC. And a dedicated glaucoma council was appointed at the outreach camps and at the glaucoma clinic to increase the patient compliance with the referral and the treatment. To make the tool more applicable for the community settings, we have simplified it in the form of this performa. This is our glaucoma screening tool here. So it has various categories like age, less than 40, 40 to 60 or more than 60. Family history of glaucoma is there or not, history of hypertension, any history of steroid use. Then the visual acuity in the form of either more than 6/18 or less than 6/18 or less than 3/60. IOP in the range of either 16 to 21 or 22 to 30 or more than 30. Then the pupillary findings and the lens status, whether it is cataract, clear or operated upon. Then anterior chamber depth assessment and the CD ratio in the form of less than 0.6, 0.6 to 0.7 or more than 0.7. And the asymmetry between the two eyes, between the CD ratio less than 0.2 or more than 0.2. Then finally, on the basis of these factors, referral was given, either patient has been referred or not. So the retrospective data analysis was done. The data from the screening records included patient demographics, family and personal history, visual acuity, IOP, AC depth and CDR measurement. Data extracted from glaucoma clinic records included gonioscopy findings, visual field assessment and glaucoma specialist notes. And the hospital records were linked using MDR number, and the outreach referrals were linked using camp ID numbers. The individuals directly presenting to the glaucoma clinic or referred by other facilities outside the pilot screening program, they were excluded from the analysis. So data was analyzed, descriptive stats were used to describe the characteristics of the patient presenting for the screening. Stats tests were used to examine associations between patient and clinical characteristics as explanatory variables and the suspected glaucoma or uptake of referrals and glaucoma diagnosis as outcome variables. So coming to the result, so duration of the pilot project was 18 months. We have examined around 23,000 individuals more than 40 years of age. Among those, 58% were men. Due to restrictions imposed during COVID-19 pandemic, the most patients were screened at our base hospital, and only for around 4,600 patients were screened in the community settings, that is outreach camps and the vision centers. So in addition to direct walk-in patients, the hospital screening was extended to include all the patient attenders who were above 40 years of age and who had not come to the hospital for a checkup for themselves, and this was done for free. Based on the referral guidelines, 2,200 individuals across all the sites were referred for the further examination as glaucoma suspect. That comes around 9.5%. Among these 2,200 individuals who were referred as glaucoma suspects, the majority were men, around 62.4%, and people aged 41 to 60 years were around 76%. Over 70% of these glaucoma suspect referrals, they had good vision around more than 6/18. So the referral from base hospital was almost twice the rate from the community settings. It was 10.5% as compared to 5.6% from the community settings. All the glaucoma suspects identified at the hospital accepted the referral for further examination, approximately 96%. Among the patients referred from the community settings, only 58% attended the referral. For those referred from the community-based screening, there was no statistical difference in the uptake of the referrals by the sex, but individuals with normal vision and those below the age of 60 were less likely to take up the referral than people with visual impairment or older people more than 60 years of age. So we have the table which shows the association between the patient characteristics and compliance with referral from the community settings. So in this we can see more than 60 years we have significant p-values here, and even the visual impairment less than 3/60, it was significantly associated. Among 2000 patient suspects presenting for examination, almost half were diagnosed with a glaucoma, that is around 48%, and this represented a screening to diagnosis conversion rate of 4.1%. So in the univariate analysis, a positive diagnosis of glaucoma was associated with female sex, older age more than 60 years, moderate to severe visual impairment, that is around 6/18 to 3/60, IOP more than 30, CDR 0.7, and the shallow AC. So all these factors were positively associated with diagnosis of the glaucoma. So this is the same table. We can see here female sex has p-value significant, even the age more than 60, same for the intraocular pressure more than 30, CD ratio also, and the shallow AC. Coming to the distribution of risk factors among the diagnosed glaucoma cases, 71% of those diagnosed with glaucoma, they had at least one of these risk factors, while 31% had more than one risk factors. Risk factors being age more than 60, again IOP more than 30, CD ratio more than 0.7, shallow AC, and IOP 21 in 30, and CD ratio between 0.6 to 0.7. So almost 1/3 of the patients with confirmed glaucoma were either blind or had severe visual impairment. Coexisting unoperated cataract was present in 10% of the cases, and another 42 patients had been previously operated for cataract in one or both the eyes. Other significant retinal pathologies were present in 78 cases, and uncorrected refractive errors were found in 287 cases. So the trap surgery was performed alone in 110 cases, and combined surgery was done in 99 cases. YAG laser was offered to 137 patients. All the patients were referred or were offered one-to-one counseling about the course of the disease, follow-up regimens, and the long-term benefit of the treatment compliance. And patients were also advised to refer their family members to the screening. So this is the flow chart, what we did. We had approximately 23,000 patients screened. Among those, 18,000 were done at the hospital, and 4,600 screening were done at the outreach camps. Among the hospital, we have identified around 2,000 patients as suspects, and in the outreach, we had 261 patients as the suspects. And out of those, 2,000 patients presented for the glaucoma workup. So out of 2,000 patients, we had 1,000 patients with no glaucoma and 48% with the glaucoma diagnosis, around 968 cases. Among the confirmed glaucoma diagnosed patients, open angle was around 58%, closed angle around 30.4%, and other secondary glaucomas around 4.24%. And the glaucomatous optic atrophy was noticed in 6.5% of the total glaucoma diagnosed cases. So coming to the discussion, so in this study we have used the data from the community-based and hospital-based targeted screening of people around 40 or 40 plus, and found that 4.1% of those screened and subsequently examined had glaucoma. 2.4% had open glaucoma, open angle glaucoma, 1% had angle closure, 0.2% had secondary glaucoma, and 0.3% had glaucomatous optic atrophy. And these results are broadly comparable with the estimates reported in other studies in India, although the research in this area remains limited and the comparative analyses are difficult due to the difference in study methods, study settings, and the definitions used. Similar to the published evidence available, the positive glaucoma diagnosis in our study was associated with older age and the presence of visual impairment. Unlike other studies, we found a positive association between undiagnosed glaucoma and being female. So gender inequalities disadvantaging women in eye care have well been documented before, and given that majority of patients presenting to the screening camps tend to be men, programs are needed to put in place specific measures to ensure that women are aware of the screening services and being run in a way accessible and acceptable to the women. Also, more research on how to facilitate access of women to both screening and eye examination services is urgently needed. So we focus largely on identifying patients at risk of vision loss from the glaucoma, and our primary referral indicators being IOP more than 30, CDR 0.7 and shallow AC, they were all associated with glaucoma diagnosis. The assessment of family history and steroid use we cannot assess. So definitely identifying patient glaucoma at very early stage of the disease would be most beneficial from public health point of view, but this will require a combination of multiple tests to be used. However, in the setting similar to one we had here, where we conducted our pilot program, this is not a viable option unless and until we have low-cost portable technology. In addition, patient compliance with referrals and the treatment early stages of disease in such settings is likely to be low. Therefore, it is a reasonable compromise to identify patients at more advanced stage of the glaucoma based on simple referral criteria by targeted community-based screening in such geographies. In our study, 92% of the patients diagnosed with glaucoma were deemed to benefit from treatment. Interestingly, in 42 cases of the patient who had been previously operated for cataract, glaucoma was not at all detected. This suggests that current system does not have the capacity to identify glaucoma patients, and the integration of additional simple tools like the one we piloted in our program will be highly beneficial. Further, one of the key purposes of the pilot was to test the feasibility of the targeted glaucoma screening close to people where people live. Unfortunately, due to restrictions of COVID pandemic, we were not able to fully assess the potential of the screening in the community settings such as vision centers or the outreach camps. Number of these activities during the pandemic were limited, and even the number of patients referred was relatively small. Even the uptake of referrals from the community was relatively low, particularly among patients who were younger and had normal vision. So the question remains is, finally this study was based on secondary analysis of the data collected by the program. We therefore could not fully assess the impact of integration of additional tests on staff workload, screening time and the cost, and also to what extent patients diagnosed with glaucoma will comply with future routine checkup and treatment, particularly if they have to incur the cost, because in this study the cost was covered by the program. So in conclusion, the glaucoma is a growing public health problem in India and globally, hence the importance of targeted screening cannot be undermined. Community-based programs and eye examination of patients presenting for regular eye checkup play a critical role in detection of the disease and the prevention of severe loss of vision. Further studies assessing the cost of targeted screening, the role of technology in improving the program effectiveness and efficiency, and the longer-term compliance with treatment will be needed to support the glaucoma policy frameworks, guidelines, and the clinical practice. Thank you. So we wanted to have a sir, our basic idea was we want to identify patients who are at more risk of the vision loss, higher risk.
Hello. Sir, kindly come to the center stage. Center. Okay. Your question, Mike, put up.
Thank you.
So,
My question is that when you talk about Hello.
yes, sir.
So if you keep taking the use of eye care reliability is quite good actually. Eye care reliability is very good.
Yes, sir.
If you're using the eye care tonometry, you can keep your cutoff around the 21 and 24. And if you keep the IOP around the 24 and making the AC depth in the account, So most of the time, if the IOP more than 21 having the shallow AC depth, most likely they patient have the glaucoma. This chances of having glaucoma detection is almost more than 85%.
Right.
So sensitivity goes, combine the both two, is become the 85%.
Absolutely.
So quite a good chance. I think you can pick up more glaucoma if you keep your IOP value little bit less. And apart from that, even the cupping, especially when we see the lot of cases, 0.7 really no actually when you get the netra using. So what we using the fundus camera using, if you see the 0.8 by seeing the 90D or 78D, if you take the photograph, always so measure the less cupping in compared to the original cupping. It's always there.
Yes.
So I think that also point you can future if you conduct this study, you can keep little bit around 6 actually. You will get pick the more glaucoma.
So
actually, basically, the 30 I agree. This was a pilot study which hadn't been done at all, and this came from Site Savers. Yeah, so they are the ones who had decided on this, and basically, as it was a pilot study, and they wanted to see like how well they could detect. And initially, it was with this like a handheld fundus camera, because these are not people who can do 90D and all that. And the idea was that they would have a software which would automatically flag these cases which had a 0.7, I mean a 0.6 cup or more, or if there was a difference also, wasn't it the difference of
asymmetry.
asymmetry of 0.2 or something like that. That didn't happen. That software pattern never happened till then. The main reason was the pilot study started, I think a couple of months, and then the pandemic hit us. So basically all the development stopped.
I think it started in October, November.
Initially the hospital patients were not planned to be included in the study, but then they had to do something. So basically the attendance, anyone, like it was not patients attendance also above 40, everyone was screened. So yeah, so that is how. So future, yeah, now again it's actually going on, but now we have to think of modifying these things. Yeah.
Regarding IOP cutoff points, so we had a discussion with Dr. Sandeep also. So he told me his basic idea is we want to focus not on the glaucoma screening, we want to focus on identifying patients which are at higher risk of the vision loss. So that's why he put the IOP little bit higher.
I agree also. Why I'm not agreeing with you? Because once you are going in a community, really, why don't you keep the criteria
Yes,
low?
now we can expand, I think. Yes,
Criteria
definitely.
low
I think
actually.
they were not sure of the sensitivity of the machines and all.
Yeah, probably.
The pilot study.
Yes.
Yeah.
So good study. Those good study.
Yeah. So now it is actually again starting. So this we have to take it forward with better.
Any other questions for Dr. Vasu, our postgraduate student?
Actually, now we have those virtual reality type of field that is one also. I was telling them we have to include 4 songs. Instead of doing Humphreys.
Excellent study, congratulations. And Dr. Suresh, maybe when you go ahead with the study in the future, you can include all these suggestions which have been mentioned by Dr. Devendra Maheshwari. Here, we would like to juxtapose another finding. The same study or a study similar to what has been conducted here in Orissa in 2019, 20, 21, 22 was conducted in Aravind Eye Hospital in 2003, and their findings are very similar to what you have found in Orissa, which means this study has relevance in our population group, in the Asian population group. So that is one good point. And now, I would like to tell you a short story about Mullah Nasruddin. There was this Maulana, Mullah Nasruddin, who was in his house. So one day, he took all the oil from the family, the entire bottle, and he went to the mosque. His wife asked him, Mullah Nasruddin, it is 8 o'clock in the night. Where are you going with all the oil in the house? He said, I am going to light up a lamp in the mosque because the mosque is dark in the night. So he went there, and his wife said, anyway in the night it will be dark, why do you want to light a lamp? Mullah Nasruddin went to the mosque and he lit the lamp. And then an angel appeared to Mullah Nasruddin and it told, Mullah Nasruddin, before you light up the lamp in the mosque, you first light up the lamp in your house. Then you go light up the lamp in the mosque. The reason for my telling the story is because our Mr. Vishwanathan is like Mullah Nasruddin of Sankara Eye Hospital. What he has done is, before conducting all India meetings, Orissa state meetings, etc. in Sankara Eye Hospital, he has decided to first light the lamp in the house and then he will go light the lamp in the mosque. So, sir, thank you very much for conducting a comprehensive program which includes not only the doctors but also our staff, our students and everybody, because before we start lighting up lamps in public places, I think the first place to light the lamp is our own house, so that our own children first have the opportunity to benefit from the light of knowledge. On that note, I should also note that in our country there is one proverb called Ghar ka Peer Maskari. Ghar ka Peer Maskari. What it means is, when we have a saint in our house, we will not respect that saint. But when there is a saint 150 kilometers away from our house, we will go to that saint and offer our respect. Because this particular saint is in our house, we will make fun of him. This is a common Indian habit. Similarly, in Sankara Eye Hospital, you have a doctor who has done maximum number of surgeries in Tirunelveli, maximum number of surgeries in Bangalore, maximum number of surgeries in Vellore, and finally he has now ended up in Orissa doing maximum number of surgeries in Sankara Eye Hospital also. That Ghar ka Peer is Dr. Sudip Das. We are going and inviting Dr. Maheshwari from Tirunelveli. He had to go to Tuticorin. From Tuticorin he had to catch a flight and come to Chennai, from Chennai to Bhubaneswar, and from Bhubaneswar to Berhampur, and from Berhampur to Samarjhola. We brought this saint from Tirunelveli, whereas we already have a saint sitting right in front of us, Dr. Sudip Das. So, I request Dr. Das, who does not like lengthy introductions, to talk to us about trabeculectomy and combined surgeries, and all of these surgeries were done in Sankara Eye Hospital. Welcome, sir.
So you'll hear a lot about the newer surgeries that are being done, the MIGs and all that subsequently. But this is where it all... So this is where it all started, and this still remains one of the most useful, commonly performed and cost-effective. If you look at these other devices, whether it's the age-old AGV or the MIGs, they're extremely expensive. So hopefully sometime the price would come down and we can use it in a community setting. So first thing is to actually know a little bit about the anatomy of the limbus. So I'll just show it there when I start the surgery. So this is the conjunctiva. Part of it is sort of speeded up, otherwise I won't finish. And this is the tenon. So what I cut was the conjunctiva, and people don't realize that conjunctiva and tenons are attached slightly differently. So you have the conjunctiva, and the tenons is depending on where in the limbus you are checking, temporal, nasal, whatever. So it's about a millimeter behind. And I prefer to remove the tenons because I find that the blood failure is a lot less. So that's the conjunctiva which has been removed. and then you dissect back a little, and this is the tenons. So I'm sort of dissecting the tenons from the conjunctiva. Make sure you don't buttonhole the conjunctiva when you do that. So it's quite a thick tenons. Not everyone will have a tenons which is this thick. When it's this thick, I feel that there's a lot more of blood failure, blood fibrosis. So I'll just pause it here. And
So you can use the pointer.
no, it's okay. So basically, this is the blue area that you are seeing. So the blue area is mostly corneal tissue. And then you have the scleral tissue from behind that. So the blue part and the white part of the limbus. Oops, sorry. So I prefer using a sort of a rectangular flap instead of a triangular flap. You can do whatever you want, but since I use releasable sutures, this is, I feel I can calibrate it, titrate the bleb function a lot more. So I'm using a crescent. Earlier we used to do it with a number 15 blade, but it's so much easier to do this with the crescent blade. So yeah, basically you can see I'm dissecting into the clear cornea.
And it should be a new blade.
Yeah, it has to be a new blade. And then basically earlier we were saying that you remove, we are taught that you have corneal tissue, you have trabecular tissue, you have scleral tissue and all that. But basically I don't think any of us go into the scleral tissue when you're removing what we are calling the internal ostium when we are creating that. So you can do this with a punch, but I find it very easy to do it with a lance tip blade. So I have a side port there just to fill up the anterior chamber, and then I'm just cutting it off. So this is basically, you can see, is entirely in the blue area. It's basically corneal tissue which you are removing, and then iridectomy, a full thickness iridectomy. And then you have to take, these are releasable sutures. So the first bite is actually through the cornea. You just saw that, the tip of the suture is not exposed. It's not rubbing against the cornea. So it's just gone through. Sorry, that part has, I think in the editing there's something. So first bite is through the cornea, then through the flap, then through the base, through the scleral part. And then basically what you are doing is, you are taking a loop you are tying it to the loop, not to the tip here, not to the end of the suture. So basically you are tying it here. So when I pull on this, the knot will get released. So you're taking 4 throws. You have to make sure that 3 throws will slip. So you're taking 4 throws. So again through the cornea.
You're taking it through the cornea so that the tip of the suture
You will be cut off. You can actually release, there is this loop here which is under the conjunctiva. You can actually release it from the conjunctiva. So it comes out like that and you have a loop to pull it out. So nothing is actually exposed initially.
Once again, sir, we have to tell you, it has to be a new suture, new needle.
It's always a new suture. The question doesn't arise. Where do you use old sutures? This is steno. It's basically a monofilament. You can't use a multifilament suture because you can't pull it after that. It's very difficult. More chances of getting infections also with that. So then you just close the conjunctiva. And you have this bit here. So these are vicryl. and I take a suture. So this is what I'm doing. I'm cutting off the ends. But then there is a bit which is under the conjunctiva, which is a loop, which has gone from the cornea to the scleral flap. So you can actually put a needle there, just pull it out, and you have this entire thing again exposed, and yank it out. If you want to, if your blood function is not good. If your blood function is good, then you really, and this is mitomycin. I don't know what you do. I don't use swabs anymore. I give 0.02%. I inject a small amount into the conjunctiva. It seems to work a lot better, and I don't have that many complications related to MMC. Yeah.
Why not? I will personally go, you should go before inject, before surgery and before tenectomy. Before starting surgery, just to inject mitomycin C. Then I think you have much better outcome.
Meaning better blebs or?
Better blebs, good blebs. There is always risk right now. Some of the mitomycin enter into the anterior chamber. Though really it is
no, this is, yeah, but it's, I'm injecting it into the conjunctiva and it's quite posterior. It's quite posterior. So I haven't really had that. And I used to have more problems definitely when I was using the swab and then dissecting and all that, so dissecting after that.
Even I am using mitomycin injection since 2014.
Yeah.
So I am the first one who started using mitomycin C in Arvind Eye Care system.
What percentage do you use?
0.2 to 0.4. Both percentage I use, depend upon the risk category. So I still insist you use before, will always have safer side.
Yeah.
Even before making the osteotomy.
Before making anything, before making conjunctival opening, before starting. I'll show you some of my bleb needling cases.
Okay.
Yeah.
So this is basically phaco-trab. It's basically a repeat of the same thing. And earlier I used to make, I used to sort of make the peritomy, lift the flap up but not enter, and then go temporal and finish the phaco. I used to find it easier. But then I said, why don't I just finish the phaco and then try, and it didn't make any difference to me. So I just went back to finishing my phaco first. And so I won't really show this part. So this is really fast because I didn't really want to focus on the phaco at all. It's a routine phaco. There's nothing different at all. Only thing is you have to make sure that your side ports are very close here. Don't make your side port here. Then you finished, you can't make your trap after that. So your side ports are very close to the temporal wound.
So this is the balance tip centurion?
This is a centurion, a regular centurion balance tip. I wish I could do surgeries this fast. So this I basically made it beyond. So that's the other thing you can do. You can either have it close or you can go really further away from that. So this part is free for your trap. So normally we make a side port somewhere here. If you do that, then you're in trouble. You can go make a nasal bleb, but I find this easier to dissect and all that. So I change my position. So it's basically the same thing, conjunctiva, tenons. People used to say that you don't dissect tenons if you use MMC, but I find that my blood failure, if you don't dissect the tenons, is still very, very high even with mitomycin. So prefer to dissect the tenons.
Actually, that's the next topic. Management of blebs.
So bleb, post-op what I do is, I will almost always, unless the bleb is large, I'll remove one suture at 1 week. And the second one, I call them at the second week, I may or may not remove. So even if I don't remove anyway, it is not going to create any problems. But The first one, most often, unless it's already a large bleb, I would probably remove it at the first week. And that's the reason I'm very hesitant doing it in CAM patients who have no review, because if they're flat AC, high FEMA, non-filtering blebs, God forbid infections, you really don't know what they're doing because they're not going to come back. It's very, very scary.
Usually with, sorry,
Yeah.
He is not interested.
Yeah, this is...
So basically in CAM patients, we used to avoid the religible sutures, especially in the CAM cases.
Yeah.
So recently we developed a new technique. I'm doing one study, probably say the result after 6 months. So what we use, instead of using the nylon suture, we're closing, you can be talking about
These are Prolene. I mean, sorry, these are Vicryl.
Vicryl.
These are Vicryl. Even what I showed you are Vicryl.
Conjunctiva.
No, I am talking about the flap suturing.
The flap suturing is Nino Vicryl.
Nino
Vicryl.
Oh.
So even if I don't remove it, probably in 4 weeks' time they are gone.
Okay, that's
So
good
these are
actually.
all Vicryl. I don't
then-
use nylon or Prolene at all.
Okay, right.
Yeah.
Then it's fine. Then
Yeah.
we can apply.
Any reason for this choice?
I used to use nylon, but then I thought that nylon I have to, sometimes they'll stick out, they'll cause problems. It's not a releasable suture. It's not a absorbable suture. So Prolene, Vicryl anyway is going to get absorbed at some point of time. So it's a lot more sensible than using this. So these are all, that's why it's slightly greenish blue in color if you see. Yeah, it's not Prolene.
Nylon sometimes come with, you keep the CAM patient.
Yeah.
The deposition, they infiltrate.
Yeah.
It can lead to endophthalmitis.
Exactly. So these are all Prolene. These are all Prolene. This is Prolene. I mean, not Prolene, Vicryl. I don't know why I'm saying Vicryl. You can see it's purplish in color. But they are monofilament. A lot of Vicryls are multifilament.
This is that ethylone 90 Vicryl.
These are by Oral Lab.
Oral.
These are by Oral Lab. So they call it some other, PGA, basically PGA sutures, polyglycolic acid sutures. Yeah, same thing. I use the same thing. I have the same thing and just use the same thing. And conjunctiva also, I prefer to use, so the knot stays inside. So I start from one, the loop is on the outside and the knot is inside. So basically it's a repeat of that. So again, these are releasable sutures. Sometimes I might, I find when I inject here, I find that there's still a lot of oozing out, then I'll put a non-releasable suture in the center of the flap, in the rectangular flap. Otherwise, I'll leave it at 2 at the corners.
Sir, can you just go back by 15 seconds? Just for the benefit of a postgraduate student, if you would observe how he makes the suture, the first bite is on the posterior side of the conjunctiva.
So I'll go to that.
Because that is done so that it does not irritate when the patient blinks after the surgery.
This is the
Yes.
This is the flap. So
See, it's on the inside.
I'm taking on this side
First.
and then going to the other side. So basically the loop is on the outside, the knot is inside. When I tie it, the knot goes inside. Hi, Ravi.
Did you notice?
So basically the knot will just slip inside under the conjunctiva. And these are the ends of the releasable sutures which I am cutting off.
You can follow the same technique when you're doing pterygium. Start from.
So here also I am taking an additional conjunctival suture. Same thing. I start from that end and then go on to.
So the knot goes under the.
Yeah. And this is what I use for the center. So center also, if you see, I'll take a corneal bite first, so that it's sort of watertight. So I'm taking a corneal bite first, and then the conjunctiva, and then it looped through this end of the conjunctiva. So the knot again sits under the conjunctiva. So this way it's totally watertight. It's not just at the two ends.
Sir, the central suture.
Okay.
Once more.
So-
Through the cornea, through the posterior surface of the conjunctiva, and then
From the top to the bottom, conjunctiva on this side. So there's a loop on the outside. And then just so basically I use one suture, one PGA suture for the whole process. Flaps, this one, whatever. So that's
What
a
is the
dexa.
injection?
That was dexamethasone, and
Still
this is
dexa.
yeah. So here you have to make sure that I'm going in an area where I haven't dissected the tenons, because the front part I've dissected the tenons. So if you inject there, it's not. It's going to go into the subconjunctival. So to go behind where the tenons is still there and inject it between the conjunctiva and the tenons.
Dr. Maheshwari wants to do the same thing, but before starting.
Yeah, I'll try that next time. I almost never do a SICS trap. So even if the patient can't afford it, whatever, I prefer to do a phaco trap. Because for me it hasn't worked that well, but I've just included that anyway in one of those rare cases where I've done. So my wound is a little different, because I always do two side. In a SICS trap it becomes very difficult doing two sides because it's such a large dissection. So basically one end of it has been converted into a sort of a flap.
So this is Dr. Ramakrishnan's technique.
I have no idea.
Dr. R.K.
I have no idea, because I have most things I have sort of developed sometime in my life, and so one side is slightly more posterior, and that's sort of like a flap, and that is where I will tie it. So this ICS is done, then again make the trap.
You edited off the SICS video, sir?
Yeah.
Welcome.
And again, this is again a releasable suture at the apex. And this is of course triangular. But then I always will take another suture here, a fixed one, because otherwise it's going to leak. So that is the releasable suture at the apex, but to close the wound there's another one here. So just hold the base of the triangle fixed so it doesn't move, otherwise it will definitely leak from that.
And you bury these two sutures.
Those are fixed sutures. And then again you can see I'm doing the same thing. I'm taking the flap suture first, then the fixed one from the other side. So the conjunctival suture gets buried. And there's one releasable suture here. Okay, I think I've reached the
Okay, so in
end
case
of
you don't
my-
need to release the releasable suture,
We leave it like that. They're vicryl, so PGA sutures. They will just dissolve, but by that time it won't increase your filtration. Because what I found is, you release sutures after 2 weeks, it doesn't really help. Unless you release in the first 2 weeks, it somehow doesn't increase the blood function much more after that. That's it. Thank you. I'll just need to transfer Ronnie George's. I don't know.
dear friend,
You'll
this
connect your
entire
laptop, right?
program
Okay,
is
good.
for your benefit. So if you have any doubt, please ask the experts.
Yeah, it's there.
Which medical college
आपका
are you
laptop पे
from?
connect करिए रच. हाँ.
Burla. And you? Any questions? No? Dr. Maheshwari is here, Dr. Sudeep Das is here. You're all in your first year or final year? Second year. You've started doing SICS? Yes. Is there any medical college where they are still doing ECC?
I think we are made to do ECC initially. I'm not
ECC?
sure some of them.
It is not a bad technique actually. Because I belong to that generation where the last ICCE was done by me. After that, ICCE was never done. So you would have done many
I
ICCE.
have done lots of ICC. I am the generation which has gone from ICC to take code, ECC to take code to SICS, take code to SICS to flat.
Well, in my case, I belong to the next generation. So the last ICC was done by me because my professor was the RMO of RIO GOH, your area. And then they stopped doing ICC with cryo extraction. And we started doing ECC. This is in 97.
I have done with cryo and with Aruga process.
And in 98, and in 1998, Arvind Eye Hospital came up with small incision cataract surgery. So we started doing that in 98. In 97, they started in Arvind. 98, they started promoting SICS to rest of us. At the same time, in Vellore, we had Dr. Blumenthal who came from Israel. So he started teaching the Blumenthal technique to all Vellore fellows around the same time, 1998, which is also a good technique. But the instrumentation required for Blumenthal is a little more than what is required for SICs. Plus, Arvind Eye Hospital had done over 5 lakh SICs in the year 1998, and they had mastered the fine art of doing SICs. So they were in a better position to promote SICs as a viable option in community ophthalmology. 1999, we had Appasamy Associates who started making economic phaco machines. So before that it was Galaxy, and Alcon had one phaco machine.
Alcon had, meaning...
AMO had Galaxy or something. Alcon had one workhorse. It used to work for years together. They came out with a phaco machine. But that... Universal.
Universal 1 and Universal 2.
Those were...
Universal 1 wasn't that popular. Universal 2 became extremely popular.
Those were very expensive phaco machines. In the year 1998, they used to cost about 12 lakh rupees. That is the time when Appasamy came out with their phaco machine, which used to cost 2 lakh rupees. Then we started doing that phaco. By the year 2000, it was established that paying cases will undergo phaco and camp cases will undergo SICs. That was the trend. That was in 2000. This is 2022. So there's a lot of evolution which has taken place. Plus, if you remember, I interrupted Dr. Das and asked him, is this the Ramakrishnan sir technique? Dr. Ramakrishnan is the chief of Arvind Eye Hospital in Tirunelveli and a glaucoma specialist. And he had come out with this glaucoma filtration surgery for camp patients, in which it is almost like a modified ECC, but TRAB is also done. Modified SEC. So that is how glaucoma surgery has evolved. And today, it has reached such a level where people like Dr. Maheshwari are implanting tiny eye certs, inserts, glaucoma certs, etc., which are so small, it's not even more than 2 millimeters, and this goes into the angle of the anterior chamber and it does the job. So, evolution has taken place over the past 2 decades, and you will see it all reflecting in the talk. So, Dr. Maheshwari, we welcome you to Samarjhola, because he is coming from the southernmost tip of our country. Exactly. There is a port called Tuticorin, which is near Kanyakumari, and there is one tiny airport. So, this gentleman who believes in tiny implants has come from the tiny airport of Tuticorin. Welcome, Maheshwari.
Kanyakumari is only
Yes. Thank you for warm welcome and very good morning, everyone. Though I feel sleepy, I started my journey at 3:30 today, so keep me awake. Okay. So first of all, thank you, Sudeep sir, Sai sir, and Sankara team to having me here. So I'm going to talk about that how to manage the trabeculectomy after the surgery. Though sir has shown beautiful video of surgeries and fantastic surgeries sir has shown with good outcome. But even though doing the excellent surgery, trab is not like the phaco surgeries, because even doing your best to best, sometimes they are going to fail. Because doing a surgery is just half part is done. Because glaucoma surgery is a bit different. We don't know how the body is going to react to your surgery, because the healing process, patient using multiple medication previously, and the way you created your surgery, sometimes lot of things are there play a role. You're doing the plain trabeculectomy, lens is there, and using mitomycin C, sometimes putting the tight suture. Those are shown the all relegible suture. Practically is not possible for this teaching. When you beginners actually, you have to use nylon suture to teach them, guide them. Sir is par excellence, so he can use the all relegible suture. So when you learn, you have to learn this literally fixed suture also to keep the balance, because trabeculectomy is something like keeping the balance between leak and maintain the anterior chamber. You want to leak also, you want to maintain the chamber also. So a nice balance we need when we do the trabeculectomy surgery. So as we say, just a completion strap is the beginning of the healing process. It takes several months to complete. And really we have to follow these cases for longer period of time. And trap can fail any time. It may be 1 month, 3 months, even a year also, and 4 years, 3 years late fail also. So what we have to do, we have to manage the initial period very crucially. Then our bleb can survive for the longer period of time. So what is the successful bleb? How we know the successful bleb is successful? So bleb should be quite elevated, it should be diffuse, there should be no vascularization and presence of the microcyst. So how we can get such a good bleb? So there are various preoperative, intraoperative and postoperative measurement are required. Though the intraoperative measurement is well described by the Sudeep sir. So always we have to take care of the minimal conjunctival manipulation, minimum intraoperative bleeding, and use of the intraoperative mitomycin C going to help for to get the successful bleb. Now my talk is today I'm going to focus mainly on the postoperative measurement to how to make a successful your trabeculectomy. So most important sign to recognize the early bleb failure, how we can recognize your bleb is failing. So look for the sign of the bleb failure. The bleb may be low or may be localized, and there's a starting of the vascularization. There's a large blood vessels is coming, and you see the wall of the thickening of the bleb ball is going to be thick, and there's an absence of the microcyst. Maybe initial period or IAP may be low or maybe the normal, but eventually once you find these are the signs are present, your bleb is going to fail in longer period of time. So what is going to happen later on? Later on you will see your bleb become less diffuse, become more vascular, flat and opalescent. And later on we going to the failed bleb, you can see in the down pictures. So what are the most common cause of the bleb failure? Subconjunctival episcleral fibrosis or the subtenon encapsulation. So where your bleb is going to fail? At the level of the bleb capsule, so the subconjunctival fibrosis, or the flap suture. At the flap, your tight suture or sometimes the scleral flap fibrosed. And the sclerostomy, what you created the sclerostomy, it can be closed either by fibrin, blood, viscoelastic, sometimes desmoid membrane, so many things can be maybe there. So this is the way I am going to elaborate in the further slides. So when we talk about the successful drug, topical corticosteroid play a essential role in the management of the successful bleb. We have to use steroid for quite longer period of time, at least minimum 3 months. Even some of the patient we give for the 4 to 6 months also, depend upon the bleb. So what the corticosteroid going to do? It decreases the wound healing process as well as maintains the fistula open. And always use the cycloplegics when you are using the planned tuberculotomy, because it decreases the inflammation as well as prevent the posterior synechia formation. And it helps in the deepening of the anterior chamber also, because in planned tuberculotomy there is a likely chance you can get the shallow AC. Then this is the measure is most underrated. It's called the distal ocular massage. When you find your bleb in first postoperative days, like 1 week or 10 days, sometime don't take certain measure. Don't take remove suture, don't cut suture on the first week. Only simply you can do the gentle massage, because some of the time these IOP is high because your ostium is closed by the fibrin, viscoelastic, blood clot. So just you give the gentle massage, see your bleb is forming, it's nice. How to do it? Always give, either you can press the adjacent to the bleb or ask patient to look up, little gentle massage with your thumb or cotton applicator down. But always keep eye on the anterior chamber. So these are some studies showing. Then coming to the 5-fluorouracil. When your bleb is become more vascularized, IOP become a high. In such cases, the 5-fluorouracil helps, 5-FU helps in reviving the bleb. So what is the dose of 5-FU? We have to give 5 mg, 0.1 ml of 50 milligram solution, and total dose 3 to 10 injections in the 2 to 3 weeks post-operatively. How to give? You can take the 5-FU in 30 gauge needle, and it has to inject it when you're going inside. I'm sorry, unfortunately I'm not having video of this because I stopped using 5-FU right now. I shifted to mitomycin C mostly. So this 5-FU you have to inject adjacent to the bleb. When you're going into the conjunctiva, you have to go in zigzag manner and inject. Why it is needed? Because it is prevent the egress of the 5-FU, because 5-FU is a highly epithelial toxic. Once if 5-FU come in contact with the epithelium, it causes a lot of PEs.
How would you compare it with mitomycin C?
It is, I will coming on my talk. So this is a 5-FU. Then coming to the laser suturolysis. Again, this is required. Those are using vehicles are not required, but standard teaching is there. We always use the nylon suture to close the flap. So either some people use the 2 or 3 most of the time. So either if you rectangular 2 suture, and using the triangular they use the 3 suture, 3 stitch sutures. So when we have to do the suturolysis can be done up to 1st week to 4th week if mitomycin is not used. You can perform suturolysis up to 8 weeks if you are using the mitomycin C. Yes, it is depend upon the patient to patient. If it's a very thick tenons, really sometimes we don't get the good function. But if you're using mitomycin C properly, you can do up to the 2 months also. It works in certain cases. Before suturolysis, you should keep in mind your IOP is high, your bleb is flat, and there's always cut single suture at a time. Don't rush for the 2 suture at a point. Be a conservative, especially when you're talking about the tuberculotomy case. Cut 1 suture, call after patient after 1 week, then cut the 2nd suture. So how to do suturolysis? You can use either Hoskins lens, though it's costly lens, using around this 25 to 35,000 lens. So if you're not having such a sophisticated lens, you can use simple 4-mirror lens and use the edge of the 4-mirror and focus it. So what the parameter you should keep is spot size 50 microgram, exposure 0.1 second, and power 200 to 500 milliwatt. Sometime depend upon the thickening of the bleb ball. Sometime your tenons are very thick, you can't cut it, so you can increase the power and cut it. So this is the video I am just showing you how to focus it. So just I am focusing it here. So this is laser light, and just this is a green laser they used. Green laser. What we rupture. Yes. Green laser what we use for PRP. That. So this is cut. So this is the, again you see in this video, again this suture is cut. After cutting the suture, some of the cases when you cut the suture, bleb form spontaneously, nothing to do because it's already there. But in certain cases, bleb won't fail. But if bleb is not forming, that means you have to apply the distal massage. If you are not applying the distal massage after cutting the suture, that means your cutting suture purpose is not solved. So once your bleb is not formed, then see in this video I am giving the little gentle massage. So just you press adjacent to bleb or inferior to bleb. Once you press it, I can see nice bleb is forming. So this is the continuous massage giving, and while giving you massage, always keep an eye on the anterior chamber. Yeah, diffuse bleb. Yeah. If you use mitomycin, we get such kind of good bleb.
One reason this is
Yeah, sure, sir.
lens is one is the magnification. Second is actually you can see the suture very well. It flattens the conjunctiva when you apply the lens. Without the lens, the conjunctiva, even if the bleb is flat, it's not totally flat. It's still raised a bit. So you don't see the suture that well. The laser doesn't focus. Once you apply the lens, it's flat, and you can actually, it's so clear. You can see that.
So next, I think, sir, using this vehicle suture, vehicle suture. So vehicle suture doesn't require to remove it earlier time. Right now we're using a nylon suture. So nylon suture, what you have to use? Always use when removing the suture. Keep in mind, always use the Orocan and Provident drops, okay, to make the sterile the area. And after that, using the non-tooth forceps, just you have to pull it. There's already loop is there. Loop, just you have to pull it on the slit lamp. Once we pull out, same things applied here also. If bleb is not forming, give gentle massage. Once you give the gentle massage, nice bleb is formed. Then coming to the certain cases, when you see everything is fine, blebs looks good, but blebs look good, but you will find out your IOP is very high. So always in such cases, always try to do the gonioscopy. You can find out your ostium is closed by the some of the blood clots, some of the iris, and sometimes the vitreous or descent membrane. In such cases, simply you can do the YAG laser and remove it. Then coming to the certain point where all of your measurement, like the ocular massage, enhancing topical steroid, apart from the suturolysis, everything fails. Then you can consider the bleb revision, which is called the bleb needling. So what is the prerequisite for bleb needling? Your IOP is high, flat chamber, or the encapsulation or scarring at the bleb level. And always see there should be some function of the bleb should be there. When you're considering bleb needling, you should consider some of the bleb is functioning, and please check the conjunctival mobility before performing the bleb needling. So how to do bleb needling? Bleb needling usually can be done either in the slit lamp or in the option theater. If you want to do the bleb needling, especially the OR, it is a more controlled fashion, and easy to do also. So when you are first time doing the bleb needling, always prefer to do in the option theater. Once you become a master, you can perform in the slit lamp also. So again, all the precaution has to be taken. Patient has to be explained well about the what surgery he is going to do, because again is kind of re-surgery, and again the chances are there patient bleb will not survive. You can may use to further drop, it may use to the second surgery also. So the proper consent has to be taken. So recent studies suggested that mitomycin C injection is more effective in compared to the 5-FU. So Dr. Sai is asking, so I am saying, so mitomycin is more effective in compared to the 5-FU. Yeah, epitheliotoxicity, mitomycin is not epitheliotoxic. It can come in contact with the epithelium, doesn't happen, nothing will happen. It's more to the ciliary body toxic. It should not go into the anterior chamber by any means. So once mitomycin going into the anterior chamber, it not only right now problem, you can get that late hypertony. Like certain cases when we see lot of fellows used to come and they do this all the surgery, we see that such kind of hypertony even after 7 year, 8 year, 10 years also. Unexplained hypertony in which the people didn't take care of the using mitomycin C properly. So some amount of mitomycin C goes into the anterior chamber or contact ciliary body. They can present with a late hypertony after 5 years, 7 years also. So that is the reason we have to use mitomycin C very judiciously. It should not come in contact go into the anterior chamber. So this is, I am showing some video how to do bleb needling. So this is the injection mitomycin C I am injecting here with 30 gauge needle, and this is the solution. I am just keeping it posteriorly. So because this again, why it is again the mitomycin C is a limbal toxic. Okay, so limbal cells should not die. So we should keep this mitomycin quite back and bend that 30 gauge needle. After bending that 30 gauge needle, you go from the 4 to 5 millimeter away from the bleb and follow along the globe. Your needle should follow the contour of the globe. After cutting the subconjunctival adhesion, you go into the under the flap where the flap is there, and the needle go under the flap. Once you go inside, you can find out the feeling. You globe become a soft, and you can see this patency has been created between anterior chamber and subconjunctival space. At the end of, you can form as you can see, nice bleb is formed. Sometimes you can see your bleb is formed too good. In certain cases, you can leave some of the viscoelastics into the anterior chamber. So it's going to help in avoid the early postoperative hypertony. Then this is the case where I am using in a phakic eye. So when you use in a phakic eye, always we have to take care your anterior chamber should not be shallow. So after giving the injector mitomycin C, I did just massage and take the corneal traction suture to get the proper hold and make the small side port and put the anterior chamber here, anterior chamber AC maintainer, anterior chamber maintainer here. So what is going to help? It is avoid the shallowing your anterior chamber. Then rest of the process similarly what I showed in the last surgery. Always go 4 to 5 meters away from the limbus and go side by side movement, breaking that fibrosis. And here when you go under the flap, you can go under the flap but avoid entering into the anterior chamber because your lens is there. So in such cases, we should not go into the anterior chamber. Under the flap, go under the flap and raise the flap. So in this case, I think one of the here thick fibrosis is there. So I went after finishing this side, I moved to the another side. So once I go to another side, my bleb is formed nicely. So sometimes really it looks easy, sometimes really is hard to do bleb needling, and outcome also really sometimes difficult to understand. Then this is the new technique, is called the ab interno bleb needling. So in this procedure, we should not touch the conjunctiva directly. We come from after injecting the mitomycin C. This even the Grover's spatula it is called. I will show you right now when it's come. So pushing the mitomycin back here again, and this side port is created, and put the viscoelastic to make the anterior chamber, and this is the Grover's spatula. So this spatula is gone. Throw the PI area and lift the flap. Once you lift the flap, you can see here this spatula is coming into the subconjunctival area here. It is called the ab interno bleb needling. So similar way you come from other side, you can see this is my spatula coming into the subconjunctival area. It is here. So this bleb needling is a less atraumatic, don't cause much hypema, and give the good outcome also. Though it need little learning curve because coming from inside out. Then coming to
stay slightly further away, obviously.
Yes.
Otherwise you can't approach.
I think you should slightly away from it. Then once you become a master, you can do the blood needling into the slit lamp, because some of the patients are very apprehensive for going into the operation theatre. They say again surgery. So once you hear you have to go for operation theatre, they are afraid. The psychological pressure will come. Again, I have to go to the operation theatre. In such cases, you can do into the blood needling into the slit lamp. After injecting the mitomycin C, take the needle. Only care here has to be taken. Don't cut the conjunctiva first in such cases. Go under the flap, lift the flap, so some of the aqueous egress, and that will give you the space to work on through the subconjunctival space. Then you can slowly go and lift the subconjunctiva and cut the subconjunctival fibrosis. So that's the care has to be taken. So like any other surgery, always blood needling have the sum of complication like hypotony, buttonholes, subconjunctival hemorrhage, shallow AC, blood leak. But avoid the aggressive blood needling because it may lead to the phlebitis, endophthalmitis and epithelial toxicity. So blood needling not only save the patient burden of the multiple glaucoma medication, but it avoid the repeat surgery. So how to manage the blood? We can use the liberal use of the topical steroid in initial post-op period. Consider the distal massage as a first step. Second step, inject the mitomycin C or 5-FU, or if not works, then you can release suture or cut the suture, or nothing works, then you can do the blood needling. So the first 6 weeks are very, very crucial. You have to closely follow your tuberculotomy or combined cases, and always look for the vascularization, extended height of the bleb and bleb severity. Thank you for patient listening.
Dear colleagues, I wish to welcome the new batch of doctors who have entered the hall. So I presume you have listened to the talk on bleb failure and management. If you have any questions, please feel free to ask. And one more thing, a humble request, let us postpone the tea break by another 30 minutes because we have to catch up on 2 more talks. Okay. Oh. As you are all aware of, the junior most staff member of Sankara Eye Hospital is Mr. Vishwanathan. and he wants to felicitate Dr. Maheshwari. Sir? Ron. Thank you very much, Dr. Maheshwari.
Yeah. Any question?
Any doubts? Questions? Yes, Ramu.
Yeah.
Mic kodu. After that.
Sir, your presentation was excellent, sir. Thank you for your knowledge, sir. And my experience with bleb actually, because I did study on bleb morphology, so I got inspired by Mayur Kamar, who was doing surgery, who were doing study on bleb morphology with UBM. So I took that as my thesis. So, sir, you told that post-operatively we are doing bleb needling. We had an experience with 5-FU actually to say, but you told that you will be directly injecting 5-FU into the blood. Actually, my teacher.
No, I didn't say that. I didn't say that. I say you have to inject the 5-FU adjacent to the bleb, adjacent to the bleb, not directly into the bleb. No. But you talk about the theory, what the textbook says. Still, the prominent textbook says the 5-FU inject. But really, we have seen the practical things. Really, it don't work injecting 180 degree away from there. Though still in right for the PG students are here. I don't want to confuse them actually.
Okay,
If
sir.
somebody asks examiner,
Okay, sir.
we
Okay,
have to
sir.
answer 180 degree away from the bleb. But really, in practical scenario, we inject adjacent to the bleb.
Okay, sir. Another question is that pre-operatively, if we use prostaglandin analogs, so we have studies says that the goblet cells of the conjunctiva comes down, so the success rate of the bleb comes down.
Yeah.
Whether it goes with it, sir?
Yes, very much. Because the patient who is using the glaucoma medication more than 1 year or more than 2 years, they have the chronic conjunctival inflammation. So in such cases, you have to stop this prostaglandin analog and all the anti-glaucoma medication. And we did one study in which we started the pre-op steroid before the tuberculotomy. And when you start the pre-op steroid in tuberculotomy cases, have the good outcome in compared to the patient without using steroids. So we have always you have to withdraw this all prostaglandin analog before the surgery.
Okay. Thank you. Thank you.
Needling, Rojo instrument, they have a different instrument, which is sharp at the side. The tip is not sharp.
Yeah.
So, but I haven't used it.
No, blade needling you can use.
Sorry.
We can use 26 gauge, 30 gauge needle. Even some people use the MBR blade also. You can anything what works.
Here is so sharp you might poke out.
But it is some people are using. So I feel personally what works in your hand, use that.
So that they say it cuts through the fibrous tissue because the side is sharp.
Yeah.
But the tip is not so pointed. So maybe it works better, but I haven't tried it.
Yeah. Yes, boss. Same concentration. I use almost same concentration. Even in, especially you're using with the vascularized bleb, in such cases always use the higher concentration because they always at risk of the failing bleb. So I use always 0.4. Yeah.
Any other questions? Any other questions from the audience? We have our next speaker in absentia, Dr. Ronnie George, who is from Sankara Netralaya. So he is not able to join us because his son has got an admission in IIT Chennai. Therefore, he sent his talk and it will be relayed now. And after that, he'll appear on Google Meet live and we can have an interaction with him between 11:10 and 11:50. So I request Dr. Sudip Das to play on behalf of Ronnie George.
So some of talk will be you see overlap between he and them. Okay.
No, it's different perspectives. Yeah, it's good. Can you connect that? Yeah, that's what. This one, because 7 months it was lying at home, totally dead, not used, so the battery has gone.
So on behalf of the PGs, I'll ask you a question until Dr. Das comes online. Supposing a postgraduate student has right now mastered ECCE with 5 sutures and they're doing a good job. Now, what glaucoma surgery would you recommend for our postgraduates?
So, which one are we doing now? Blood management, is it?
No, sir, we'll go to the other one.
Okay.
Recent advance.
Okay.
So I personally recommend, So I personally recommend instead of ECC, learn SICS, upgrade the institute, get the training from the good place, learn SICS first, and start doing the SICS rep. SICS rep is a beautiful surgery. If time permit, I will show you if I have some of my surgery. It's very elegant, very safe surgery, and really it doesn't require much of the instrumentation, especially working in the rural area. You can easily do it, like your routine SICS.
Okay, shall
So
we
if
start
possible,
this?
you prepare that
Sai?
talk also. Yes, sir, you're ready.
Because he is time bound, right? Ronnie, he'll only be so.
That's okay.
we
You
have to
start.
finish it.
Volume varudappa.
Oh,
Is it here, sir?
yeah. Okay.
Volume? Or I'll just keep the mic next to the speaker.
Why is it not?
Ah.
That's it.
So for the sake of the postgraduate students, we'll try to play one SICS teaching video also. And please feel free to ask not only doubts but also to give suggestions. What do you want to see? So the aim of this entire program is not to show off what we can do, but to cooperate with you and show what you want to learn. So please give your inputs and we will definitely accommodate your interests.
You look at the different approaches that you have for the MIGS. You basically have
Yeah, it's coming.
whichever
It's coming.
MIGS,
Just
whichever
increase the
Zen,
volume a little bit, if possible.
and the
You have to increase here.
Here it's full. There.
green cable.
Auto volume. Sir, record pa.
give you a brief overview of all the MIGS, the indications. I'll show you one dual-bed video. We'll talk about efficacy and put into our practice pattern. When you look at the different approaches that you have for the MIGS, you basically have the subconjunctival MIGS, which are the Zen and the pressure flow. You have a number of Schlemm's canal devices, the Kahuk dual bed, the trabectome, the iStent, the hydrus. There are suprachoroidal devices such as the side pass and the iStent supra. So all these, except for the subconjunctival MIGS, target areas of filtration which have previously not been targeted surgically, at least on a routine basis. So good afternoon, and again I apologize for not being there. I've been asked to speak briefly about the newer MIGS, and I'll give you a brief overview of all the MIGS, the indications. I'll show you one Kahuk dual blade video. We'll talk about efficacy and concerns and how they fit into our practice pattern. So when you look at the different approaches that you have for the MIGS, you basically have the subconjunctival MIGS, which are the Zen and the pressure flow. You have a number of Schlemm's canal devices, the Kahuk dual bed, the trabectome, the iStent, the hydrus. There are suprachoroidal devices such as the side pass and the iStent supra. So all these, except for the subconjunctival MIGS, target areas of filtration which have previously not been targeted surgically, at least on a routine basis. And these are the various devices available to you. You have three versions of the iStent, which came out first, which was actually at that time the smallest human implant available. And this was basically this little device with a snorkel which went into the angle. With the new generation, you have the iStent Inject, where you have this little plug-shaped piece which goes into the angle. In fact, you have two such devices placed in the angle, and now you have the iStent W, which has a slightly larger diameter, and it is recommended that three of these are placed in the angle. You also have the hydrus microstent, which is a little larger device than the iStent, and that fits into the Schlemm's canal. It's a little bit more difficult to use, but some of the results that you see with that are fairly promising. You have then the suprachoroidal devices, which is the side pass microstent and the iStent supra. The side pass microstent was withdrawn from the market maybe 4 years back because of concerns about endothelial cell loss. The iStent supra is still in trials and yet to come to market. The Solex Gold stent was being used in the past but has not being routinely used now, partly because of approval and cost concerns. And you have the Miniject, which is the latest on the market, and that's again a small suprachoroidal stent. And the suprachoroidal stents are an interesting area to be in because that is completely untapped, but they also carry risks of fibrosis, of endothelial loss, and of new suprachoroidal complications that we haven't thought of. So these are what the two commonly available and globally available Schlemm's canal devices look like. On the left, you have the eye stent with two devices put in there, nicely placed. And on the right, you have a hydrous device. You can see how much larger it is compared to the eye stent. So these are the two commonly available angle devices. Right now, the eye stent is available in India and the hydrous is not. The bleb MIGs are basically the Zen gel stent, which is inserted by an ab interno approach. That is, you go through the antechamber and you enter in the subconjunctival space. And the pressure for microstunt is an ab externo approach where you open the conjunctiva and you enter from the conjunctiva into the angle. So both these devices are likely to come to the country sometime soon. And this is what a nicely done Zen implant on the left side looks like, and a nicely done pressure flow implant on the right hand looks like. Keep in mind that this is not how your average device would look like. Especially with the Zen, there are significant needling rates, and any complication that you can get with a bleb dye, you can get with these eyes too. So what are the indications? Generally, the indications are mild to moderate glaucoma. There's a long list of contraindications: neovascular, traumatic, malignant, uveitic, congenital retrobulbar tumors, and elevated episteal venous pressure. It's important in our country to remember that angle closure glaucoma is a definite contraindication. So the angle MIGs require good gonioscopy skills. You need an open angle, like I mentioned before. You require a functional Schlemm's canal. Keep in mind that what you're trying to do is you're trying to increase flow through the Schlemm's canal, and if you have a very scarred Schlemm's canal like you will get with late POAG or with many forms of late glaucoma, a MIGs device is unlikely to be useful in that situation, an angle MIGs. The bleb MIGs have all the risks of scarring, as I mentioned before, and all the risks of all the infections that you get along with conventional trabeculectomy. So this is a Kahug dual veil, which is can be done as a standalone procedure, but it's usually combined with cataract surgery. It's this little device. I'll show you a little bit more about it as we go forward. For all angle procedures, keep in mind that you need to have a microscope which can tilt. You need to tilt the microscope head towards you by 45 degrees. You need to tilt the patient's head away from you by about 45 degrees so you can visualize the angle. And you, of course, require a surgical gonioscope. So this is a Kahug dual veil procedure. What I've done is I put a surgical gonioscope there, and you can see the angle, the KDBs. And what you'll see there is basically the patient has had cataract surgery. You see it on GV inside the eye, and this is the little, and that's what it looks like. So it's a small little device with the angle and molecular measure. You can see little blood from there, and that's it's to about 90 to 120 degrees after, and that's it. So then you need to take out the little tag of trap measure, and the surgery is over. So how do the MIGs do? I mean, this looks fairly straightforward, fairly easy to do, but this is just one KDB glide, and it takes a little bit of training to do it. How do they do in terms of IOP control? So the best two devices that you generally have are the Miniject and the pressure flow. And this is information with the pressure flow microfilm, and you're seeing at 5 years a fairly good reduction with intraocular pressure. Most of the devices don't give you this type of device, and don't forget that this is a bleb device. So these two actually give you the longest term data on MIGs, but not every device works like this. So what has also been proposed that if you're going to do cataract surgery and you can put in a MIGs device at the same time, you reduce the need for an interventional glaucoma surgery in the future. And this has been shown by this large sort of study presented by Ahmed and by IK Ahmed, where they found that the rates of undergoing a glaucoma surgery were almost 70% less if you did an early phaco MIGs. So the argument is that you combine one of the MIGs procedures with a phaco when the patient develops a significant cataract, especially if they have early in disease, you may be able to prevent a future glaucoma intervention. But this is one way of looking at the information provided. In general, when you look at the efficacy of MIGs, you can see that even what is advised you find that with mild to moderate glaucoma, a lot of the MIGS are okay. Mild glaucoma, most of the angle MIGS seem to be fine. With moderate, you can think about the larger angle MIGS like the Zen, the PRESERFLO, or the GAT. But with the advanced glaucoma, most of the time MIGS are contraindicated. If you're going to do it, you have to go with a suprachoroidal or a bleb MIGS. MIGS are not always safer than traditional surgeries. You do see significant rates of hyphema. You can see hypotony. You can see a blood leak. You can see stent obstructions. And resurgery rates are also not uncommon after these devices. So just like any other glaucoma surgical procedure, they are also as unforgiving as any glaucoma procedure, and that should be kept in mind. What about compared to trabeculectomy? And this we're looking at just the subconjunctival MIGS versus trabeculectomy. So when you look at the PRESERFLO, which is possibly one of the more efficacious devices, you still see that at 12 months, trabeculectomy gave you better intraocular pressure reduction than the PRESERFLO. In terms of medication reduction, again, the medication reduction was also greater with the trabeculectomy than the PRESERFLO. With the Zen, again, similar pictures for two of the three studies actually showed you that trabeculectomy gave you better intraocular pressure reductions than with MIGS. And intraocular number of medications required was also similar or less with trabeculectomy. So cost effectiveness is the other big issue, especially in India. And when you look at the multiple cost analysis that have been done, they're all fairly consistent in saying that there's limited evidence available that these devices are actually more cost effective in the long run than medication or conventional surgery. So this graph basically shows you what you expect to see in terms of intraocular pressure reduction. The lowest graph, the lowest brown sort of line shows you what happens with phaco alone. The dark blue line on top of it shows you what happens with SLT and ILT. The light blue line shows you what happens with an eye stent in terms of percentage reduction of intraocular pressure as compared to baseline. Above the orange line shows you canaloplasty or trabeculectomy. The bright green line is basically endoscopic laser therapy. And right on top, you have the two things which seem to work the best, the trabeculectomy with mitomycin or a tube shunt. So both of these give you an approximately 50% intraocular pressure reduction. Most of the other devices like the eye stent and others seem to give you something around 25%. So keep in mind that these are not trap substitutes, but they could be adjuncts when you are combining it with a cataract surgery. But also keep in mind that these require newer skills, and especially good gonioscopists, which are absolutely essential. They are not a substitute for traps or tubes. They may have a role only in early disease, and they have their own safety issues, their own learning curves, and cost is likely to be a major concern in most parts of the country. Thank you for a patient hearing, and I'd like to acknowledge Dr. Bhaskaran for some of these slides.
Ronnie, can you hear us?
Yeah, I can hear you.
Yes, okay. So a hearty welcome to you first of all from the Sankara Eye Hospital, Orissa. Dr. Sudip Das is here. Dr. Devendra Maheshwari is also here from Arvind Eye Hospital, Tirunelveli. You come here and say hello.
Hello. Yeah, we heard your talk on the new MIG. And yeah, that's very good.
Good
morning. I just had
Hello. Morning.
Okay.
Hi, Devendra.
How do these get discharged?
No, not really. Once they sit in, there are very, very few reports of the eye stent getting dislodged a couple of times. But in general, no. Once they're in, they stay there. The others with the Zen, there have been a few cases of erosion through the conjunctiva. And with the side pass, not that. With but generally, no. Issues is another thing. So, sorry, which one? No, scleral necrosis. No, scleral necrosis has not been reported. I'm not sure whether there are single case reports here or there, but in general, no. You can get erosions, but necrosis, no. It's possible you can do. No, you can do it. The only thing is, see, because most of the Schlemm's canal devices you put in the nasal or the infranasal area, and that's not an area where we go to for a trab at all. So it's the superior conjunctiva is superior conjunctiva is usually spared. The superior angle we don't fiddle around with, so that's usually not a challenge. Morning.
Medical College. She is from the
Hello,
Burla Medical College. Yeah.
Good morning, sir. Sir, I am Dr. Shomi Roy from Introoperative. Sir, I want to know which one is the better.
Yeah. So, in general, the one with the best success rates is a trabeculectomy even today. So, MIGS is not a substitute for the trabeculectomy. In some cases, with early disease, may be controlled on one medication. Patients who are undergoing catheter surgery. Your case selection has to be very good. It's not a substitute for trab or an implant.
Sir, can you repeat, sir? You are not audible,
Yeah,
sir.
so
at time.
Okay, so the trabeculectomy continues to be the gold standard for glaucoma surgery. MIGS is not a replacement. Can you hear me?
Ronnie sir, you mean TRAB is not the substitute for MIGS? TRAB will be TRAB. In certain cases, when IOP is needed, the mild to moderate IOP control is needed, we can consider the MIGS, right, sir?
Yeah, you can consider it in open angle glaucoma with sort of where you can visualize the angle well.
Yes, sir. So, in the open angle glaucoma cases, when you need mild to moderate IOP control, you can consider the MIGS. But still, TRAB is the best surgery. TRAB good, the very good IOP control. If patient need the good IOP control like the early teens or the low teens, definitely we should consider the trabeculectomy. Am I right, sir?
Yes, Dr. Devendra.
And
Okay, sir. I'm asking, what is your preferred choice in MIGS?
Sorry, I didn't get the question.
What MIGS would you like to prefer? What MIGS you do, sir?
Okay. Yeah. So I do the KDB, and I do the endocyclophotocoagulation and the iStent. We still don't have access to the Zen or the other subclinic level devices. So for me, I think when you look at cost considerations between the KDB and the iStent, the KDB becomes a little easier to use because it is definitely much cheaper. The iStent is a very elegant procedure, but if you really want good reductions, you need to use the inject, which is 2 devices. And for that cost, you can probably do 10 trabeculectomies. So I think cost is a major factor when we look at our country.
Sir, how is your experience about the KDB blade and how IOP control you experienced?
So I have not done a huge number, but in general, I have done it on patients who have been on one or a combination of 2 drugs. I've done it along with cataract surgery. And in the few that we have done, we have seen almost 30 to 40% IOP reductions. Follow-up is fairly short because the device has been available in India only for a short time. But at least in this short time, we have not seen anybody who didn't respond, at least in the short term. But you can have some hemorrhages, you can have a short-term IOP spike because of the blood.
Thank you, sir. One question from
Good morning, sir. Dr. Sashwati. I'm Dr. Sashwati
Good morning.
from KIMS, Bhubaneswar. Sir, I would like to ask, what is your experience regarding GAT? As we talked about the cost effectiveness, I've been trained in glaucoma from Arvind Pondicherry. Right now they're doing a lot of GAT with proline sutures, and they say that it's very cost effective. So from that point of view, how do you think it works? Do you think it works better than eye stents, implants and all? Because
so that's a good question, and actually you should answer that because you have seen more GAT than I have. We don't do very much of GAT, we've just done a few. But in theory, in theory,
I was a fellow. They started it recently. The recent FECO summit when Dr. They had called Dr. They had in FECO summit they had demonstrated the GAT technique with proline sutures.
Yes,
Swati ma'am is doing from US.
from David Grover.
Yeah.
So
they were telling that we are using it with proline because it's more cost effective for the community, for the cancer.
Yes. I agree with that. In terms of cost, it's definitely more effective. Technically, it's a difficult surgery to do, and many patients actually land up with some amount of require them.
Ronnie, can you hear us now?
To settle down,
Yeah.
to settle this all up. The other one, the routine travel home after a week that are there are basically week or 10 days, and remove the network
Okay.
is required. We cut it down. So considerations is surgery. Now we are to get patient whom we can maybe send leave our head back later. I can come a challenge. It is from the
Oh, we have lost the network.
we can revel back.
Prasanna, what happened to
I cannot really do it with this sort of that person, and I'm not really sure how going to inhibit drugs that trap mesh work. Going forward, if you get a flow through the trap mesh work, how will a GAT impact that in the future? So those are the two concerns. But otherwise, yes, it's a good low-cost solution. You can't hear me?
Ronnie, you're talking like John F. Kennedy, pa.
Am I not audible
Yeah,
again?
you please talk slowly.
Am I audible?
Yes.
Yeah, can I pressure down? Yeah, can you hear me?
Yes, we can. Yes. Yeah.
Okay.
Ronnie,
want me
can
to
you
repeat
hear
what I
us?
said?
Yes? Can you hear
I
us
can hear
now?
you.
Yeah.
I can hear you. Once the other is really, once you have removed the entire trabecular meshwork. Do you want me to repeat what I said?
Yes, yes. And this time a little
Yeah.
bit slowly. Not like John
Okay,
F. Kennedy.
So basically, the GAT, as you know, it strips the entire trabecular meshwork. So because of that, you are more likely to have a little bit of bleeding immediately after surgery. And to keep that bleeding under control, we leave a little bit of high molecular weight viscoelastic in the eye. And that requires slightly closer follow-up post-op for the first few weeks till the pressure settle down. So in terms of the post-op care required and follow-up, it's a little longer than a routine trabeculectomy or a routine tube. That's one thing. The second thing is, it is definitely cost-effective. Technically, it is much more demanding on the surgeon. You have to have very good gonioscopy skills to be able to do it. The two concerns that have been raised by many people regarding the GAT is one, you are actually doing a 360-degree trabeculotomy. So if that happens, any future Schlemm's canal device, you cannot really use confidently in these patients because that area is all opened up and scarred. Second, if you get a drug in the future which really works well on the trabecular meshwork, or you get gene therapy that targets the trabecular meshwork, how will a history of GAT impact those two procedures is a question. But otherwise, it's, safety profile is pretty good, except for the hyphema, it's pretty safe. If you have good skills, it's definitely a good procedure to know.
I'm going to demonstrate all the such things. So thank you for you making my way much easier.
Yes.
Oh, excellent. I'm good.
Thank you. Ronnie, a big thanks to you from the bottom of my heart. I know that you are involved in the admission of your child for IIT Chennai. So may God bless your child. Congratulations to you. And we have the junior staff member of Sankara Eye Hospital to felicitate you and thank you, Mr. Vishwanathan.
Oh, thank you.
Good afternoon, sir. Good afternoon. Good afternoon. We are extremely thankful and happy that your participation, though you could not be personally present, on behalf of our Sankara Eye Hospital, we convey our heartfelt thanks to you, sir. I am actually in Pammal, Sankara Eye Hospital, Pammal. I have come here for participation in this program and for the last 2-3 months to develop this center. We once again convey our heartfelt thanks to you. Thank you, sir. Thank you.
Thank you, sir. And
Thank you very much,
for not
Ronnie.
being there in
Thanks.
person.
Yeah, bye. Thank you. Okay, a big round of applause for Dr. Ronnie. Yeah.
Thank you. We'll meet you in November in GSI. Thank you. Yeah. Thank you. Thank you. Good day.
Okay. Ronnie's talk. He spoke many things. What is your take-home message? Your name, introduce yourself.
Good morning. I am Dr. Pradyumna Mishra from Vimsar Bulla. What I understood is that the newer mixed devices, they are not better than TRAB and they are not supplementary to TRAB.
Well, not supplementary, they are a substitute. That's okay. Good. Okay. And from Dr. Maheshwari's previous talk, what is your take-home message? Forget all these files. I am coming to you too, pa. You be ready. About left management. My take home message is even the best bleb performed by the best surgeon can fail. So do not be worried if your bleb fails. You always have second attempt, third attempt to improve the filtration surgery. In other words, never ever give up. Okay, that's my take home message. Anyway, you doctor, what is your take home message?
Sir, I am Dr. Satyavata Jana from High-Tech Medical College and Hospital, Bhubaneswar. Sir, in my story, sir, talk, I got the take-home message that we have to carefully evaluate the bleb regarding the thickness and the infections and inflammations, and before going to manage, we should do digital pressure to try to make the filtration more important than surgery.
You
Sir, what I understood is that how we can do bleb, how can we form bleb in surgeries, and we have to use a steroid before for 2-3 topical steroids. Sir.
Let us ask doctors.
Me anytime, because by seeing the kind of audience you are on landing page, this talk really I don't say it's not mean to you, is mean to you all, but little bit you feel is not getting it, not getting connected, you can stop me any slide, I will explain you at any moment. So feel free. I want to be more interactive than just I'm just talking and giving the lecture actually. So really MIG is literally quite new for India, not for US. US they're doing from long time. So we look for the Indian perspective, what we can do and how we can modify the things for our population. So I'm skipping just slide. I think sir has well covered all these things. So only thing we have to focus why glaucoma is still improperly treated. What's the reason behind it? So this is the current paradigm be used for the glaucoma treatment, like medical management, laser, then coming to the surgery. So what is the problem with the medication? They need one medication, two medication, three medication, and again the recurrent cost and the compliance of the patient. And above that, above the more than 2 years, more than 75% of the patient require two or more medications. Then coming to the laser, though really they are a good safety profile, effective, but they need the repeat treatment. Either talk about the ALT and talk about the SLT or MLT, what is coming after 1 year, 2 years, it need the repeated treatment. Then coming to the tuberculotomy, really tuberculotomy is a wonderful, amazing surgery, easy to do. So we will little bit more talk about the complications of tuberculotomy medicines, and we can tell the name of the drugs. Yes, tell me first. Very good. Second. Second. What is there?
More than pigmentation, what else you see? Atrophy.
Not steroid. Steroid don't cause. Actually, this is also heterochromia. This more. This is pigeonologue. What is this? Third one. Conjunctival. Why? Which drug cause? Brahmanodine. This is fourth one. What is called? Allergic conjunctivitis. Follicular allergic conjunctivitis. How many percent people will get? 30%. 30 to 40% of the Brahmanodine patient in long-term therapy, they got the allergic conjunctivitis. So this is, I don't know, you people know, no? This is the newer glaucoma medication like the netarsodil and reposodil. You probably pharma company people have make you know the name Natalo and Repatec, row kinase inhibitor. There is a row kinase inhibitor, Repasodil and Netarsodil. Though really they are the very good drug, they works well, but again they are also having some complications. So you can get this Netarsodil, such kind of the corneal edema in certain cases, and in the cornea vacillata you can see, but it's a reversible, good part. And apart from the most common complication, they get the severe hyperemia. So either you are practitioner or the PG student or whatever, when you are prescribing such drug, please talk to your patient. You can get such kind of hyperemia. Otherwise, patient come with you. What drop doctor you give? मेरी आँख पूरी लाल हो गई है. They don't come to you for a practice. PG you can do it. Once you go into the practice ना, they say doctor ने कौन सी दवाई दी, आँख खराब कर दी मेरी. So please talk to patient giving such medication. Even for PG analog also you have to talk to patient, because they are also come with some kind of hyperemia. So now we talk about the trabeculectomy. Really is a gold standard. It's still gold standard. Nobody can compare still to better surgery for glaucoma than trabeculectomy. It's still gold standard. Nothing is needed, no device is needed. It's very cost effective, can achieve very good IOP control. Okay, but again there is something new. Everything we need advancement. Something have to be changed. Down the 50 years of evolution of trabeculectomy, not much has been changed actually. If you look for the certain complications, really we are carrying some risk when you're doing the trabeculectomy. So more than 40% patients have the complication. Apart from that, 50% of the trabeculectomy function lost at the end of the 5 year. And so many patients can lead to the cataract. And these are again some of the complications you can see: endophthalmitis, bleb leak, choroidal detachment. And when we come to the tube surgeries, again tube surgery, you can have the diplopia, plate exclusion, tube exclusion, and sometimes you get the irritation, constant irritation. So what should be the new things? So there is a large treatment gap between the same medication, laser, and the high risk filtering surgery. So in this scenario, MIGS, minimum invasive glaucoma surgery, will come, and that will fulfill the gap. So these are the new present day glaucoma surgical option we are having. So we'll come to here. So this one part is coming the medication and laser we can do, and second part, extreme part, we can take the trabeculectomy and tubes. So when we coming to the patient who is in the early to moderate glaucoma, we are managing with medication and laser, but again the cost is concerned, some side effects are there. So what this a huge gap between these conservative management versus the high risk tubes and traps. So somehow here the surgery, these called the micro-invasive surgery or minimum invasive glaucoma surgery, fulfill this gap. Now coming to this, the newer term, micro-invasive bleb surgery. I will talk a little bit later about it. So what is the ideal surgery? So ideal surgery should be as effective as the trabeculectomy. It should be reproducible. There should be no bleb, easy to perform, and cost effective. These are ideal, but as we know, really hard to get something in the ideal, but somehow minimum invasive glaucoma surgery qualify these conditions. So I.K. Ahmed and Sahib Iqbal define the minimum invasive glaucoma surgery. It should be ab interno approach, minimum traumatic, having the good efficacy, high safety profile, and rapid visual recovery. So some of the ideal surgery, we can qualify some of this. But there is again some concern regarding the ab interno approach. Some of the surgery ab externo also write off, some people considering as a MIGS. So you are asking, where is the trab role? So when we want, this is the answer for somebody asking, where is the trab stand? When we need the really IOP control like 9, 10 or early teens, really we have to go for the trabeculectomy. When we need the IOP control in the early teens or mid-teens, we can consider such surgery, minimum invasive glaucoma surgery, when you want the IOP 12, 15, target IOP. And subconjunctival MIGS, this can be defined as MIGS, can be considered above the trab. After the MIGS, you can consider the subconjunctival mix that we call the gen implant. I will show you later on. So what the MIGS do? MIGS reduce the IOP, having the good safety profile, low risk, and rapid recovery. And these are the various studies have shown really the MIGS having the very good efficacy. If you look for the trend in the US, really there's a lot of shunt process has been going on. And if you see the upcoming trend, look, this is the trend, MIGS going to up, and look the trap is going to come down. So this is the recent trend is changing. Once the change, we really follow the West. Unfortunately, fortunately, we follow the West. It's still same thing going. So again, that these MIGS procedure are going to increase. If you look at the estimate of the 2020, look up to 2025, what is going to happen? Most of the glaucoma surgery, almost 50% surgery will be the MIGS. Why? Because they are the very good safety profile, very easy, fast recovery. Right now, patients don't want to wait for anything actually. They want immediate relief. Even some patients come for phaco, they want, I come by driving, want to go by driving actually. Such kind of demanding patients are there nowadays. So they said that here for any MIGS surgery, really our tubercle outflow system should be works well. That has to be keep in mind. So where the MIGS target, as already shown by Dr. Ronnie Jars. So MIGS target the label of the Schlemm's canal, subconjunctival space, and suprachoroidal space. So here, unfortunately, there is no device right now available which work on suprachoroidal space because CyPass has been withdrawn from the market because of the lot of endothelial damage. Then major what the MIGS work at the level of the Schlemm's canal and at the tubercular mesh work and some of the subconjunctival space. Here there is some debate. Some of the gene implant people don't consider as MIGS because it's involving the conjunctiva. Again, the same risk for the scarring is present in the gene implant. So here today my talk, what we are going to talk about the eye stent, GAT, lot microhook tuberculotomy, KDB blade, and the bang. I'll describe later on. So what you should do when you're doing the MIGS, most important thing you should be master in the intraoperative gonioscopy. I don't know how many people have you, anybody has seen the angle? Anybody has seen angle? No, really. Even I have not seen. If you say that 2-3 years back you ask me, have you seen the angle? Really, I have not seen the angle. We just see only beautiful picture in the textbook only. Skull spur, ciliary body, anterior tubercular mesh, posterior tubercular mesh work. Really, it was really awe feeling. When you see the first time angle, really is awe feeling. Really, we can see the angle. We just imagine, the textbook data I have seen. But you see, really is awe feeling. So what surgeons should know? Surgeons should be master in gonioscopy. First of thing, they know the landmark of the your angles and should be intraoperative practice is needed. It's not like that if you can do the phaco, anybody can do the MIGS also. It have little bit learning curve, but anybody can do. When we talk about the patient, there should be neck mobility, no head tremor, cooperative patient, angle should be visible. So this is direct gonioscopy. Sorry, I talk about direct gonioscopy. Yeah. Oh yeah. Right. This is the direct gonioscopy. You can do practice in direct gonioscopy. Yeah. So how to do? What you have to do? You have to rotate that patient head away from you, and 30 to 40 degree, and angle that the microscope have rotated toward yourself, 30 to 40 degree to visualize the angle. First thing, and second thing, your table position little will be the up reverse Trendelenburg position. And you need, this is the only thing, you need the direct gonio lens. This is called the Swan-Jacob gonio lens, and this is a modified Swan-Jacob gonio lens. How we have to do, I'll show in one video, but just picture I'm showing you. This is the lens has to be held in a non-dominant hand. So it's a left hand. So when after holding it, you have to apply the viscoelastic over the cornea, and we have to dock it. Once you dock it, then you can see such a beautiful picture. So only 3 steps you have to learn. First, positioning your head away from you, tilting the microscope toward yourself, put the viscoelastic onto the cornea, put the right gonio lens, and you it's temporarily, yes, sitting temporarily, and you can see all the structure nicely. Okay, so these are the certain things I will go. So now coming to the gonio assisted transluminal tuberculotomy, it is called the GAT. So this procedure first described by the Devin Grover and Fallman et al. So what we are going to do in this procedure, we are threading the eye catheter or suture into the 360-degree Slem's canal. Okay, simple as simple. What you can understand this. In which case we have to do that GAT, like the patient who have mild to moderate stage of the glaucoma, they are having the mild cataract with or without cataract. You can do with cataract also or without cataract. When you are doing without cataract, you have to be careful. You should not damage the gonio. No, sorry, you should not damage the lens capsule. And certain secondary angle closure case, secondary open glaucoma cases, you can consider it. It works beautifully. So these are the various publications has shown the good outcome of the GAT. So first I am showing the video of the eye science catheter. So the first described by the Devendra Grover and Fallman et al. So what he is doing here, just see. Though there is no I will say my surgery, I will show the how to dock the lens. So what he is doing here, this is the MBR blade he is taking, and he is making the nick at the level of the posterior tubercular meshwork, junction of the anterior tubercular and posterior tubercular meshwork, to get the Slem's canal. Once you make the nick, there is always mild bleeding will be there. And this eye science catheter, it tip has the light, that light illuminate. So whatever you make the goniotomy, through this goniotomy, this eye catheter has been passed. So the advantage of this having the light is coming here, and you can visualize it where it is going. It needs 20 to 25 strokes to pass the 360-degree at least. So once you begin, really is little bit need learning experience and learning skills are required. So once come to the other side, you just hold it from the other side and pull it off. So just steering the Slem's canal all 360-degree. And after that you just have to wash it and maintain the anterior chamber. So now coming to here, you are talking about the cost. So when you talk about the eye science catheter, it's costing $750 US. Right now dollar is increasing. I don't know how many people are aware about the financial thing, but you should know it actually. Being a postgraduate, you should learn the finance also. I don't know this for I'm telling you. You should learn finances from the PG level also. Nobody teach finance to us, even the being a consultant also. Really, this should be part of your PG curriculum. Learn the finances in your PG days only. So keep market on the stock market from right now only. Right now dollar is 82. So you can multiply by 755. So how costly it is? 55,000. Yes. So how we can do the GAT you can do in the $75 with the good lenses actually. Almost you can put the acrylic or the IQ also with 70. So these are the instruments required for your GAT surgery. MBR blade, 30 gauge cannula, Helon GBO viscote, Swan Jacob gonio lens, and the fiboproline. And this is the thing most of the place not available, is a low temperature cautery. This one thing, and second thing is the gonio lens. These are the two costly things you have to spend money.
How much does this?
Yes, the Swan Jacob costs 55,000. One time investment. Low temperature cautery you can get upper swami, you can get it easily, but you have to know how to, from where to get it actually. If you upper swami, people can provide you. Rest, nothing is costly. Only thing you have to learn the intraoperative gonioscopy. So this is I do routinely, since 2 years I am routinely doing this GAT. I think volume is very less.
That's okay, you can give.
Okay, yeah. So similar way, what I am doing, I am just keep my patient position away from me. It should be 30 to 40 degree away from me. And similar way, I think sorry, I done before only. Yes, just I am rotating the microscope towards me. Only thing you require, your microscope should have the tilt. That's a prerequisite for that only. If it is that's sufficient. We don't need eye lumina for everything. Just your microscope should rotate. So rotate microscope toward yourself and patient away from you. Then put the viscoelastic. After viscoelastic, I can see all the angle. Only thing here you have to do, I'm just sharing some practical tips. Once you see the angle, really don't jump into the surgery. What you have to do, once you see the angle, you make the high magnification. You have to see all the angle structure properly. You identify where the anterior tubercular meshwork, posterior tubercular meshwork, and Salam's canal. Once you do repeatedly in a cataract surgery cases, you can identify, because we have learned so much the structure of the angles. So once you do it, then this is the fiber proline tip and this is a cautery. Just you have to bend it, make the umbrella kind of tip, and make the side port incision in nasal area, and this suture has been passed here. Okay, and this is the MBR blade I am using, called the goniotomy, here 2 to 3 millimeter. Okay, here. So once you do the goniotomy, you see the Salam's canal, posterior wall of Salam's canal, and this the suture I thread into the Salam's canal. So it's continuously. This edited video is not easy really. It has knurling curve. It requires a 20 to 25 strokes. You can see other end of suture has came. So one hold it, and other suture has to be pulled off. Similar way. This is the first case. This is again the second case. I can show you much better goniotomy. Again making the tip of the suture. So this is again making the goniotomy. So look here, making this here. After mating, just push the suture into the Salam's canal. Okay, this is edited.
Is it possible to insert it at the wrong place?
Yes, you can. Yes, you can. Yes, you can. It goes under the iris sometime. It can go to the suprachoroidal space also, though very rare. This is very, very rare. Most of the time you go under the iris actually. And sometimes go under the iris, you feel the resistance, or your people got distorted. To avoid this, you have one more dyed gonio lens that we use olden times. That lens you can use where it is suture actually. So if you are posing properly, you get the right place first time, it will go only the Salam's canal smoothly.
One more thing, before inserting should we inject visco into
Yes, your whole procedure always should be well maintained. I think more than that, always use that Orocort or Viscoat during the making the anterior chamber.
So earlier there was the visco cannulastomy, but that you went from outside.
Yes, that now we are doing our other machines inside also, outside also. But olden days we are doing the outside.
From outside.
Outside.
Found the slums canal, you threaded it through
yeah.
that, and then did the same thing.
Did the same thing only. But that's outer open. The conjunctiva is not spared. Here the whole conjunctiva is spared. Anytime you can do the trap. So this is we published. I think anybody you want to interested, you can see the step by step. This IGO video has come. It's available in IGO. You can see in YouTube it is coming. So step by step how to do the GAT. It is there. So now coming to the trabectome. So trabectome is again, this is a machine based procedure. Here again we strip the tubercular meshwork by using the electrocautery. Again problem is this machine is costing 35 lakhs and each probe costing the 50,000. So one probe machine, people are saying you can do the 2 to 3 cases, but frankly speaking after 2 cases cautery stop working, this probe stop working. So you can understand per patient cost you the 50,000. So this is the trabectome. Okay. Though again this is some recurrent cost, capital expenditure is more, so it's not popular in India, but still some of the institute like Saraf, Sunita Dubey is doing, and one more place Chandigarh, PGI Chandigarh, 2-3 places people are doing this trabectome surgery. So now coming to the KDB, it's called the Kahook dual blade. So it works also similar principle of the trabectome. What is used is use the actual blade, and taper end of the blade goes into the Salam's canal and shift and rip the tubercular meshwork. So I will show in video, you can understand well. So this I started 6 months back only doing, because it recently is available in the India. So similar way, after completion of that phacoemulsification, I am skipping the phacoemulsification part. Again the same way, I am tilting the microscope, keeping the patient head away.
That's the centurion at the back.
Yes. And maintaining the anterior chamber and putting the, already I put that visco over the anterior chamber, sorry, over the cornea. And this is the focusing the lens, focusing the angle, most important, always no hurry. When you're doing such surgery, you have to keep patience. You have to focus properly. Sometimes patient head will move, so you have to adjust the patient head, and patient should be little cooperative. This is the Cahook drill blade. Do you want to see it again?
Almost like chopper.
Yeah, almost like chopper. Modified chopper. Very steady. So here this animation. So it goes into the tubercular muscle, strip, sear and strip the tubercular muscle same way, on the other side, similar way like this. So 2 to 3 clock over this side and 2 to 3 clock over another side. So this is the surgery, actual surgery. So this is the quick drill blade. I am focusing it, going into the tubercular muscle and removing that. And the bleeding is a good part. Whenever you you see the blood, it is good. Actually, that means you are right plane. When you go see the blood, your Slem's canal. So reflex from Slem's canal is always good sign.
Is it possible to damage the root of the iris?
Yes, yes. If your hands are not proper, it needs some practice. So you have for that what we encourage to do, to whom we teach, first do the phacoemulsification. After doing phacoemulsification, shift the patient similar way, take your Sinski, go and touch the tubercular meshwork. First you see the tubercular meshwork, you can identify the angle. Once you learn the identify the angle, then take the Sinski, just touch it and come out. So it come into your muscle memory. Go and touch, go and touch. That's the way I used to my junior MO. How to teach it actually. So this is the Cahook drill blade. Then again, this is again Cahook drill blade costing the $350 US. Okay. So this is the alternative. What Indian perspective? What we can do? What we can do? We can change it. We can make it ab interno needle goniectomy. It's called the bang for the buck. Yes. Okay. So in this procedure, what we just 25 gauge needle. Like we making the system, just turn inside. If very less, system very big. Just tip you need, bend up. So I'll show you. This is the again the bang. You can do it. First finish the inside. Here over the bed like this. So this is the needle, routine 25 gauge needle, nothing, no extraordinary things. See, this is the tip, just above the tip, just bend it like this. Like this. Yes, this is good. Focus it. And this is almost like KDB blade, but KDB blade has more guard, it has little bit thin guard, so you have to little bit experience it. Just take it out, 3 clock over this side and 3 clock over another side. Every procedure, always reflex bleeding will be there, you have to wash it clearly. At the end of surgery, when you're making the anterior chamber, you have to leave some of the viscoelastics into that, especially the Orocot or viscoed little amount of. Keep your eye little tight, because once the eye becomes soft, there's always chances of reflex bleeding, and hyphema is the most common complication of the MIGS surgery. So no need to worry about it. Some viscode eye left, it should be tight. This should be, ideally said, this should be a pressure of 30 to 40 mmHg should be there at the end of the surgery to maintain your glow. So this is the Tenito microhook tuberculotomy. So I started doing is 1.5 years back, because I have given the thesis to one of my postgraduate, and really that's also works beautifully. It's almost like a Cahook drill blade, but only end is not sharp, end is blunt. So it is a kind of a Sinski hook actually, but it's called the modified Sinski hook actually. And the various publication has been demonstrated, but they all done in the Japanese population, not in Indian population. And somehow what is done in Japan, US don't accept it. I think still war is going on. Whatever done in Japan, they don't accept still. They don't accept it. What you done, they don't say it's not valid. So somehow it's still the European population, some of European population, some of the Japanese population showed the good outcome of microhood tuberculotomy. So this is the surgery. Again, similar way, after finishing, I'm escaping the phaco part. So put the viscoelastic over the cornea, make the anterior chamber tight again, and this is the, and then coming the micro hook. This is the micro hook inserted through the side port. Is coming from the right hand side and left hand side. So this is the hook, and this hook goes into the Slem's canal and just sear it. It's so beautifully exposing the Slem's canal. You can see white. This white bony part is the posterior wall of the Slem's canal. So most of the resistance we get at the level of the trabecular meshwork, you're removing all these and exposing the posterior wall of the Slem's canal. This I am doing sitting temporarily, doing the nasal side. So now after that I am opposite, come opposite and do the another side. So I am almost reaching the 220 to 270 degree area. You can't do 360 degree. You all max to max 220 to 270 degree. Another side you can do like that.
From the nasal side.
Yes.
So you're basically going over the patient.
Over the patient. Yes.
And then
doing it. It's a little cumbersome. Little tough.
What if the patient has a big nose?
I first slide is for you. Big nose is a big hurdle for MIGS. Really big hurdle. You should avoid such patient. Yes. Yeah, even if whatever you do, your maneuver, nose come in your maneuver actually. Tilt everything. Every MIGS surgery you have to tilt the patient head. Yes. That's a basic need to visualize the angle, not doing for surgery. Because the tilting is the only making the parallel axis, light parallel axis. Then only you can see the angle actually. Not for surgery we need.
Then you can't do the surgery in casual.
Yeah. Yeah, so really we have the 6-month follow-up. We did the one study in which one patient ran with tuberculotomy with phaco, and another group is the only phacoemulsification. And we find out at the end of the 6 month, tuberculotomy group has the good IOP control in compared to the phacoemulsification alone, and it need the little less medication in compared to the plain phaco group. Interesting part is there, we did the study, we didn't find out any significant difference when we did the 180 degree tuberculotomy or did the more 270 degree. Its outcome is same. If so, that conclude if you do the 180 degree is more than sufficient. You get the equal amount of the IOP outcome. Now coming to the last, this is in the trend. Probably the company is pushing very hard. The glucose is pushing very hard to eye stent to all the phaco surgeons. They don't want glaucoma surgeons. They want phaco surgeons to do the eye stent. Beauty of this stent really is the smallest stent implanted into the human body. Is really very tiny stent. You can't see with the naked eye. Sometimes you have to see very clearly. Then you can identify. You can see in the how thin is there. This is the eye stent. Can you see here? This is the eye stent. This is here. So smallest, tiniest. So good part there what the company say, it designed to improve the aqueous outflow through the natural physiological outflow. So what is this stent is doing? It is not disturbing the much tissue. It is hardly taking the 2 to 3 micron, that part. It's just going to the Slem's canal. So through the trabecular meshwork going to Slem's canal, connecting the out collector channel. So it's saying it's more physiological, not disrupting much tissue. So it creates the bypass through the trabecular meshwork through the Slem's canal. So this is the here outer inner part, and this is the outer part. I will show you in this video. So these are this part stays into the anterior chamber, and this part goes into the Slem's canal. I'll show you in the video. And these are the some of the, for example purpose, they have the 3 type of eye stent generation 1. Generation 2 is called the eye stent inject, and third one is coming the eye stent inject W. So right now in Indian market we have the first one, eye stent 1 and eye stent inject 2. Last month only we get into the Indian market. W still not hit here. US they are using right now. So I have only few experience about the eye stent. Single first generation eye stent costing the 65,000 device cost. Okay, and second eye stent inject is costing the 1,20,000. Okay, third one is still not in the Indian market, but I feel really it is not about that money. Right now you see lot of the insurance patients are there. It covers insurance. Yes, it covers an insurance. So if you Bangalore, lot of people are doing Narayana and Nidradham. They are charging 95,000 for eye stent first generation. Okay, so well, I think down the line, the future, patient will accept because we are getting from reimbursed from the insurance. So patient will be happy to.
Will start making
Okay, so I have the few experience. So this is the my one of the video of the eye stent. So just similar way, focus into the angle. They're giving this lens with you, free lens. This is a disposable lens, but you can use them multiple times. So this is the eye stent. They come like the one injector is there. Just you have to slide it. Once go into the Schlemm's canal, you just push inside it and release it. Really, it looks easy, but really I find it literally need the learning curve also. So right now, every coming the you put in it, grass. Put it, it's come preloaded only. Preloaded only. It's come two actually. One right side, one left side. Go into the trabecular meshwork. You have to eject like this, hold it, then release it. Okay, it's easy actually. It's a press. Press. Then this is another side. As shown by some of the concern of Roni Jal sir, this eye stent doesn't affecting much your trabecular meshwork. So any other procedure you want to do, you can do it. So this is, once you do it, you see some of the bleeding, you have to wash it and check it properly, either it is properly placed or not. This is the most important part for the eye stent. So I think these are the surgery what we can doing right now. So for theoretical purpose, right now this is a large trial done for the hydrous stent, and this implant goes into the Schlemm's canal. It is 6 millimeter long. So this is provide the scaffolding for the Schlemm's canal and maintain it for the longer period of time. I have no experience in Indian market. It is not available. This video by I.K. Ahmed. So I am showing you just similar way. This coming in one injector. This injector go, take this injector. Again you have to make the small nick. A small nick you do that. take this and just you have to release. When you after making the nick, the device is come out and goes into the trabecular meshwork inside. Here is trying to do to go into the right plane. So this is the device. It goes into the trabecular meshwork. So though this really has a promising outcome, is a very big study has been done. It's called the Horizon trial, and this Horizon trial has a very good outcome in compared to the previous eye stent devices. So still. Now coming to the microinvasive bleb surgery, this is called the gel stent. I am just showing the video. I have no personal experience. So just to have an idea how the gel stent work and how it is. It connect between the anterior chamber into the subconjunctival space. Just like Ahmed Bal, but it is ab interno. It's going from inside eye out. Okay. So I am showing here. So this is the implant. Once it come in contact with water, it become a more flexible. Otherwise, it is hard. So this is the injector of this gel implant. So as I saw, like any other surgery, you have to use this dried Gonio lens and make the incision at 6 o'clock position here. So from 6 o'clock position, this inferiorly. Through the inferiorly, you have to see the angle with dried Gonio lens, and then you have to come out through here, come into the subconjunctival space. Then you have to rotate it. After rotating it, you have to slide that. Injector has slider. Just you have to slide it. When you slide it, that implant has been delivered into the subconjunctival space. So this is the implant is coming. This we have to slide it. This coming to the subconjunctival space, and they're maintaining the direct communication between subconjunctival space and to the anterior chamber. You can get the immediate good IOP control, but again this device again have the similar problem like the trap we have. Subconjunctival fibrosis, scarring, close the valve. So that has to be there. So that's why some people don't consider it as a MIGS, but some company promote as a MIGS. Okay, so this is a third category, just for namesake. This is suprachoroidal implants. These are the ab interno. They can be considered as a MIGS. Some ab externo, like the gold implant, Aquasant, Starflow. Just for namesake, you should know for postgraduate, but it's not available, commercially available in the market. So this is again bypass withdrawn from the market because the lot of corneal endothelial loss was there at the end of the 5 year. So it's withdrawn. Right now, iStent Supra, it is going to suprachoroidal space. It is still in the trial. US FDA not given the approval yet. Probably 1 or 2 years we'll get the approval. Then we'll see. So in the present scenario, to answer your question, in the present scenario, MIGS fits into the mild to moderate glaucoma of the patient. When really glaucoma is very advanced, tube and trap has to be considered. So just to summarize, MIGS combined with cataract surgery provides safe new option for IOP reduction. MIGS does not affect the outcome of the future incisional surgery, and trabecular tube surgery should be considered when significant IOP reduction is needed. Thank you for patience listening.
Excellent. Lovely talk. And sir, I told you, he is one of the best speakers. And by now I'm sure you are convinced.
Absolutely.
Right. See, excellent talk, Dr. Maheshwari. Dr. Das and I, we had a discussion. He said site savers want a glaucoma program. So what shall we do? I said, sir, there are the best speakers whom I know. We will invite you. He said, Devendra Maheshwari and Ronnie Jha. Das sir said, I know Ronnie. Ronnie is known. Who is this Devendra?
I actually met him, I didn't sorry.
I'm very junior that time, sir. I met you.
So I told him, Devendra Maheshwari is a non-glamorous, but serious academician who will do justice to the topic. And I want to take full credit for bringing Devendra Maheshwari.
Thank you, sir. Thank you.
He's an excellent speaker, very understated but hands-on. I request our postgraduate students to kindly make use of Dr. Devendra Maheshwari's expertise. You come here so that you can note the answer.
Yes. Can you remove it?
Yes, we can.
Any question you can ask anytime.
Yes. Give me the other mic.
You can ask without mic, the small hall. We can. Yeah. Yeah, actually it depends upon the why we can't, I can't tell you amount because some eye is small, some eye is very big, some eye is large actually. So how we take this, how we form the anterior chamber after the FICO or SICS similar way. If you talk about theoretically your cornea theoretically should be 30 to 40 mmHg pressure should be there. But really how to measure 30 to 40 mmHg, practically I am asking. Really theoretically is like that. How to measure is difficult. So what the practical tip is there? When you form the AC nicely, at least you in the 0.5 cc viscoelastic. I use Orogel. So you use Orogel or Orocort. Even you have viscoat, you can use the viscoat also. When you put it, you can see your cornea should not indent. When you use your cornea should be free. Once you tap the cannula, it should be hard. Really, it should be stony hard. Like when we learn the SICS, we make the football eye. Correct? Don't take other way. We make the so tight with the corneal edema. So in such, after the MIGS surgery, we have to make literally really hard glow. and next day post-operatively IOP will be the normal. Don't worry about it, because what you are doing, you are creating a flow, direct flow from entry chamber to the distal collector channels. So whatever you're leaving it, it's all flows there. So, and apart from that, what initial post-op period, when initially is for 4 to 6 hours, it's a high risk of the, once you hypertonic, high risk of the high fever or bleeding you can get. Once you get the bleeding, really an MIG study, don't worry about it. I have done almost 120 cases. One patient, one or two patients required the AC was. One patient need that vitrectomy also. It goes into the behind. It got vitreous hemorrhage also. So frankly, it can be there. So we have aware of it. One case vitreous hemorrhage. Had to do vitrectomy for that. Two patients went for the AC was. So it's part and parcel once you do the surgery.
Another thing is that you said that I stent when you're keeping it, that comes like preload.
Yeah.
So when you're keeping it, sometimes it is misplaced. Then how do we have to remove it and give a new eye stent, or we can use the same one?
Only I can give you the theoretical answer of what I heard from other. I don't have personal experience of dislodging it, but what is happening, really company is hiding something from us, definitely. I can inject stage 1. First inject come really is displaced and dislodged. Why? Because it's not done by the glaucoma surgeon. It's done by the all phaco surgeons. Really they are not doing it good actually. First of thing, they don't identify the structure very well. So what happens, once it's dislodged, it's difficult to find. You can't find it. One of them. Once it's gone really. Hardly you can find it. But once you find it, you have to take it out, put the new one. So right now what the new eye stent coming, the two. One right side, one left side. Okay. So this is the third one. You see the W, I saw the picture. Why come with W? The new eye stent is coming, it's come with W. W means wide. The base become a wide. So you can easily see it and locate it where it is. And it's very easy to implant by the any one. That's why coming the W. So base become a much bigger inside. And this port become a 4, 5, 6. So you can engage the more of the collector channels.
This proline which you're using, what? That's what,
5 proline. 40 previously, we are using 50 proline. Yes.
I'm saying that like they are having Retrospective, Tuberculotomy and instead of hospital. So what I want to know is like post-operatively, like in the management level of care that we review for the patient, which is the minimum requirement is best for the patient. Like post-operatively, like in CAM patients, least care. Because in like trabecoplasty,
Plasty means I don't know.
Sorry,
Tuberculotomy. Tuberculotomy definitely leads that more frequent follow-up danger. Really, in such cases, that really works beautifully. It doesn't require much follow-up. It requires a single follow-up, like we call for the phaco after 2 weeks. Then after, I used to call my patient after 15 days and 1 month. I don't find unless some hypema is there, then I call frequently. Usually no. Then 15 days and after 1 month. So one thing, apart from that, some of the patients, we are living in coastal area. I stopped doing trap in the fishermen's. In summer? Fishermen. Yeah. The high risk of the trauma. Yeah. So in such,
also very close to the sea.
that's why I'm saying that. So in such cases, works beautifully actually, because they're more prone for the trauma and all these things. They come with all these things, and always see water come in contact with the blood. In such cases, this GET surgery works very beautifully. Even the tuberculotomy, it works very good. I do in all such cases.
It's almost a closed eye surgery.
Yeah, closed eye surgery. So everything is closed.
You have a good future, man. Next time you can come with Audi, sir. GAT is very useful in your area.
She's a lot further away. Yeah, the 60 kilometers, not that far. 60 kilometers from the sea.
Yes. Any other questions? So do you change the eyepiece field or the positioning of the microscope? Do you change the eyepiece of the microscope?
Nothing, sir. No, nothing is required. Only just we have to tilt the microscope. Nothing is required. Just we tilt the microscope. The knob is there. We just tilt the microscope. Nothing is required. No IC. Nothing is.
What you're saying is that you might want to tilt it up again because it will go down.
No need. No. Eyepiece keep in what position you using, you keep in that position only. Just you have to tilt the microscope like that only.
Devendra.
You can use. It's better to use. But once you do the phacoemulsification, is I don't use. Personally, I don't use, but it's better to use it. Especially in phakic eye, it's better to use. You can avoid the trauma to the anti-lens capsule. This is good to use.
If I grasp your question properly, it is some microscopes have tiltable eyepieces, and in some microscopes, the entire microscope head can be tilted, and it has to be tilted.
Yes. Sorry, I didn't get you. I didn't get you. Right. Yes. So that microscope
You have
has
no
to be
excuse, doctor. Whatever microscope you have, you can do this. You should do it.
Now,
either you tilt the whole base or you tilt only the eye.
You have to tilt the base anyway.
Whole base. Yeah.
You have to tilt the base, otherwise you won't be able to see through the Gonio.
So
Exactly.
recently,
For comfort, you keep the eyepiece at wherever you want.
So please understand, it's not the eyepiece, which matters. That is for your comfort and fine tuning. The entire head of the microscope has to be tilted.
So recently I learn it. So last meeting I learned it, and LUPI Siddharth Dikshit, what he used to do with normal microscope. So what he just doing inferiorly. So what he did, had the position rotate down, and our scope is always like that only. What we use now, we operate like they already tilted. So without tilting he is using, but I'm not saying this is an experience he is doing, but I don't know. This is a new way to do it with basic microscope. You can do it.
Any questions?
You can check it.
Sir, any other questions from our consultants? Shankara? Yes, ma? Yes, come.
And actually, tuberculotomy, goniotomy almost same. What a goniectomy? Goniectomy means you are stripping the tubercular meswork. Tomy means you are just making a hole and ripping out. Tenectomy means removing that part actually. KDB blade, we remove that part. And bang, we remove that part. While in that what will they going inside and loop and ripping it off. Like opening is that, opening the Sillens canal. Here what the other procedure is doing, cutting it and removing some part of the tubercular meswork. The goniectomy. Which one? Actually, it's a long thing actually to explain. So what is there? What the physiology of the outflow system? They say the most of the collective channels, like say 60 to 70% of the collective channel remains in the intranasal area. So what we are doing, if you are doing that more than 3 to 6 clock hour, is more than sufficient to get the good amount of the IP control. Now there is a big debate between either we should remove it or just tear it. Really, it is debatable. Some people still say we should not remove the tissue. Once you are removing the tissue, that means your future certain drugs, like now the Rahikanage inhibitor, they work on the tubercular meswork. As Dr. Johnny told, some work on the gene therapy. It will not be possible to work actually. So it's a debatable question. Actually, should we remove it or keep it?
Remove half, leave the other half.
Yes.
Yeah. I am like panchayat leader. No problem. You remove one half, leave the other half.
Yeah, so some of the people, what they do with the hemigate. They do 180-degree hemigate, half of they leave it. Yes, sir.
So the leaks that you are describing, beautifully they are being very good for open angle glaucomas.
Yes.
So can we do for closed angle glaucomas? Cataract surgery
I-
by synovitis, then
I don't want to confuse the PG student, that's why I didn't told you. I have done it few cases. Right now, recent trend is there in the US also. Even one of my colleague, Pratik Mahajan and Amritsar, he is doing some of the cases, angle closure. And some of the cases undoubtedly works very good in the GAT, especially GAT works very good in angle closure glaucoma also. But once you get the cynical angle closure, you should avoid it. The high risk of bleeding, and you get the iridolysis also. So once you did the YACPI, angle is visible, you can do in angle closure also. I have only 5 to 7 cases of experience in angle closure glaucoma. So I'm not commenting much.
Okay,
And I don't want to confuse to the PGs, because the common indication of MIGS is still in the open angle glaucoma.
Actually, when you were showing those surgery videos, some of them you could see the iris processes.
Yes.
That's why it occurred to me, what if it's iris processes the peripheral?
No, they are the all iris processes. No, I don't show you. I don't show you.
No, I'm saying theoretically, in case they were glass instead of iris process.
Yeah.
What would happen?
Now recent trend is there. People are doing an angle glaucoma. But it's still theoretically correct. You should say open angle. No need for cyanoculitis. Really no need for cyanoculitis. You can do without Gonio cyanoculitis. Just identify the Sellem's canal and go sit inside. All under block. Oh, no topical. They really, why? Two reasons. I forgot to tell you. When you do such your corneal incision should be more corneal. It should be no limbal incision because the bleed will affect your visibility actually. So mild hypema also cause a lot of disturbance. So kill the corneal incision. Then we use a lot of pressure of viscoelastic to maintain the glow. Because once you use first time you're using the left hand as a non-dominant head to keep the lens. So invariably you're pushing the hard. Once you're pushing the hard, you have to make the chamber very hard. Once you make the chamber hard, patient feel the pain actually. So better to do always in the block. Umbrella big two. If it is sharp, it can go anywhere. Like sir told, it go into supracortical space. Also, it go to the keep that track. And it's smooth. It's go into the canal only.
Now, with regards to all our risk taker surgeons who want to try under topical, etc., don't do it. I know one famous philosopher who told me one proverb in Kannada. He said, "Kirikiri beda." What he said was, you ophthalmologist, patient has trusted you and come to you for good surgery. Do that. Don't try Superman, Avenger techniques in other people's eyes. So that is the philosophy of Kirikiri beda. Don't do.
Yeah. I 2 years I did topical phagotropiectomy. 2 years I did phagotropiectomy continuously, all topical cases. Only thing what you have to do, this called the Burwell anesthesia. Only thing you have to spend 15-minute time into the block room, talk to your patients, what you're going to do. He or she should have faith on you. Really, you can do topical phagotherapy. But that much time or effort you have to put into it, and put at least 4 to 5 times of the
Barricade,
you can do it.
And
but
one more thing, you should add ECG leads, not to the patient, to the surgeon.
Well, when I was there, actually we did this for a short time. We used to connect the halter to the surgeon, not to the patient, and see like what is happening, the complexity of the surgery, how it goes up and up.
As it is, life expectancy of ophthalmologists is very less compared to other fields of medicine. Therefore, I suggest that you all give the block and do the surgery peacefully. Okay, and stop buying ECG leads for yourself. Okay, doctor, thank you very much.
Thank you, sir.
Excellent talk. Big round of applause for Dr. Devendra Maheshwar. Yes. Now we will connect Dr. Ronnie's second talk.
So it will be similar to his probably, but we'll see. There may be some.
And I'll tell you why I wanted two experts to talk on the same topic. Yes, madam. Ask immediately. No, good question. Good question. What matters the most is doctor's comfort. Second thing is, most of the drainage takes place infero-nasally. Therefore, it is better, the results are better if you sit temporarily and do it at the 3 o'clock clock hours. So 3 clock hours, this side means 3 to 5 or 6 o'clock, and from 3 to 2 o'clock or 1 o'clock. So that is better.
Yeah.
First question.
So if you see, this is the right eye and this is the left eye. So number of the collector channels found in this area, they are like the 40, 50, 55, 60. Okay. Percent. Yeah, 60, 70, 55%. So why? That's why most of the people think what we are going ultimately, trabecular meshwork, Sellem's canal, and the outer connector. So these outer connector channel maximum in the nasal area.
Inferior and nasal.
Inferior nasal area. That's why we sit temporarily and do the nasal side.
Now that is for the, basically the anatomy. So you have the Schlemm's canal, then like you said, you have the collector channels, then it goes into the episcleral vessels outside. So more of these collector channels are in one place in the eye. That's why you choose that place.
Yes. Second question. Yes. Yes, you can give subcutaneous block. You can do subcutaneous block right now. Another new technique also. It's called Arvind Eye Hospital Pondicherry. Forward tube have you have assessed na give there. So this is one forward tube is there. Arvind Eye Hospital Pondicherry. What they're doing? What's the problem with subcutaneous? You have to cut it, make the CL open, then we have to give it. So always potential risk for the large opening, keeping the conjunctiva open, and chances of infection, theoretically chances of the infection. What you can do for this, you can use the punctum dilator. You've seen punctum dilator? Use the blunt punctum dilator, go to the intranasally and make a small hole, through the hole, you put the subcutaneous. Right? Okay. So that's the one way you can do it.
What is your name, ma? Good question.
Nice question.
Yes.
Sarita.
Huh?
Sarita.
Oh, she is your student.
No, she's our VCT. She is one of our staff.
Optometrist.
First, right from the beginning.
Very good. Excellent, excellent.
Practical questions actually.
Very good. Amma, congratulations. And here I would like to make a blanket statement. Why is it that we have senior consultants, experts in glaucoma, ophthalmologists, postgraduate students, optometrists, and MLOP visual technicians? The reason is we are all together to make sure that the human race can see properly. We all have different roles to play, but the end statement is that we all exist to make sure that people see properly. And one more thing, there is no ego from where the suggestion comes from, because the person who found out that people who undergo acne treatment in the United States are prone for dry eye was an optometrist, not an ophthalmologist. The person who found out that people who take medication for acne are most likely to develop dry eye because the acne medication prevents the sebum secretion. By the same mechanism, the meibomian glands do not secrete the fatty layer, because of which the tear film breakup time is altered. This excellent finding was made by an optometrist, so I want to compliment all our optometrists here for making a wonderful contribution to ophthalmology. With Sudeep sir.
No. That is not trabeculectomy. This is, he's talking about the other MIG surgeries. I'm sure even trabeculectomy you must be doing superior.
Superior. The bleb must always be hidden by the lid.
You haven't seen me do any of these things.
Exposed.
What he showed, we haven't done any of that here.
Okay. Thank you. Sir?
Yeah, I'll just start the thing. Hope the volume and all is okay.
Hello, it's a pleasure to be part of this meeting, and I'm sorry I cannot be there in person. I'd like to thank Dr. Sudeep Das and Dr. Mohammed Sai for the kind invitation. I'll speak to you a little bit about postoperative bleb management today. So keep in mind that whenever you look at a bleb postoperatively, you're looking for signs of fibrosis, like a shallow bleb vascularization or increasing intraocular pressure. And the levels at which you need to look for this the fibrosis are usually subconjunctivals or subtenons, subscleral, or look for a block at the ostium. All of these can cause a result in a bleb failure. Also look for other causes like a leak, which need to be addressed postoperatively. So when you assess a bleb, in addition to the height, the extent, and the vascularity, take a close look at the edge for a leak. Look at the intraocular pressure and antechamber depth, and feel the bleb. And this is one of the few situations where you would consider palpating in ophthalmology, because feeling the bleb, basically rubbing your, pulling the upper lid over the bleb with your thumb will give an idea of what sort of pressures are there in the bleb. confirm, like I told you, that the ostium is open before you do any major interventions, and this is not necessarily very early post-op, but a little later down the line. So in addition to the blood morphology, what else do you need to do early post-op? You need to massage, because when you massage, you will get an idea of whether the blood increases, how much effort do you need to get it to increase, and you also get an idea of the extent of the blood post-massage. So this first case is about 5 days post-operatively. The antechamber is deep, intraocular pressure is about 8 millimeters of mercury. The baseline IOP is 32. So if we expect the intraocular pressures to be 8 with a baseline IOP of 32, you would expect to see a fairly large blood, which we are not seeing here. The blood is fairly shallow. So one of the possibilities is, of course, ciliary body hyposecretion because of immediate post-operative shock. So what you can do is you can give a gentle massage here to see what is happening. Because with a gentle massage, if the blood forms, you keep the conjunctiva away from the skeletal bed, and that reduces the risk of fibrosis. But also keep in mind that any shallow blood that you see with a low IOP could also mean that there is a small leak, and you need to actually do a Siedel's test on all these eyes to see whether there is a leak, because an early leak will lead to early failure. And if the leak is mild, then you can try conservative treatments such as patching or a large diameter contact lens, especially if you have a deep anterior chamber. If the anterior chamber is shallow, rule out a choroidal detachment. You can still continue trying patching or a bandage contact lens. But if the leak is very brisk or the conjunctiva has retracted, you may need to consider resuturing. The second case is 5 days post-operatively. The anterior chamber is fairly deep. IOPs are 14. Blood does look a little congested. And it is flat, and you can see that I'm doing some massage now. So when I'm doing the massage, you keep watching here, and you will notice that the blood starts increasing in size. You can actually see it around this edge. You can see that it is increasing. So this basically what is happening here is your conjunctiva is elevating quite easily, but it requires massage for the fluid to come out, which means the resistance is at the level of the skeletal flap. So you have two options here. One is you can consider releasing the blood, the releasable early, but the IOP is only 14, so releasing now might land up with hypotony. Or the second option is that you start giving 5FU injections, and whenever required, if the pressure starts going up, you can give release the releasable at that point. This third case is a retrap, 15 days post-op, and this is the original blood, where you can see a little bit. This is the new blood, and there's a fair amount of vascularization there. So this is vascularized, and you will need to start giving 5FU in that situation. So here is another, again, a vascularized blood that you're seeing there. With massage, it's difficult to get the pressure down. So we're doing a fair amount of massage, see how much you're massaging there. We released one releasable, and the pressures came down to 12. So this is a patient who now requires 5FU and daily follow-up, because you have to take a decision to release the second releasable, but to keep that blood going with massage and 5FU. If you've taken off, if you don't have a releasable suture, then what you can do is you can model as a suture license, and it's a brief video to show you what happens using the Mandelkorn lens here. And basically, this is a lens with a little dimple in the front, with which you can place on top of the bleb. And what you will see now is you can actually visualize this suture, and with just a couple of shots of a YAG, basically use a very small spot size of 50 microns. You can actually see it cut. So if you don't have access to a Mandelkorn lens, you can use a 4-meter gonioscope, the edge of a 4-meter gonioscope, not the central point, the edge of a 4-meter gonioscope, and this is what the bleb looked like post argon laser suture lenses. This fourth case was 15 days post-op. Anterior chamber is deep, intraocular pressure of 34 millimeters of mercury, and the bleb is relatively flat. And you can see now I'm massaging with superior massages. You can see that the blood here is really not elevating at all. Now, if direct massage doesn't work, sometimes what helps is that if you can try indirect massage. So I'm going to try an indirect massage here, which is basically I'm going to ask the patient to look up and massage from below, because you can apply a great deal more force this way. And let's see whether that helps. And again, nothing really very much. But with aggressive massage, you can see a little bit of a bleb forming. So this is somebody who needs needling, because here the level of fibrosis is under the sclera. You've taken off the releasables. There is no other option left. This part of the conjunctiva is fibrosed. There may be subscleral fibrosis too, and you would need to do needling in order to get this bleb to function. You can also, if the bleb does form, then what you can do is you can actually teach the patient home massage. Home massage is always taught indirectly with a massage from below, just like I showed, like you're showing you here. With that, with very frequent home massage, you may be able to keep this bleb patent. But in this case, where you're seeing no change, you will actually need to do needling as an option here. So this next patient is, this is 35 days post-op. Antechamber is deep, intraocular pressure 34, there's a large bleb there. Here again, if you cannot get the IOPs down with massage, you will have to consider needling or 5-FU or anti-glaucoma medications on a short-term basis, because this is early encystment. But the best options before you start any glaucoma medication are to try needling with 5-FU. So basically what happens is when you look at this encysted bleb, you can see this thick wall around here, and that's typical of an encysted bleb. Most of the blebs will have a lot of tissue inside here, but the encysted bleb, the entire tissues are pushed to the periphery and the wall is very, very thick. So this is how we needle these blebs. And this is basically a bleb being needled for failure. So you can do it under block or topical. And what we do using over here is a 27 gauge needle. Here you're using conjunctival fibrosis that is going on. And you can actually start to see the bleb form just close to the tip of the needle. You can see it's starting to elevate. A little bit of sublingual hemorrhage is fairly common, and you can see now that you're seeing a shallow diffuse bleb forming all over the place. Now I'm going to try and open up that too. You may need to form the anterior chamber. There's a lot of fibrosis, but here you're pushing in saline and you can see that the bleb has formed pretty well. Now we give an injection 5-FU away from the area of the bleb to help this to go. But this patient again requires topical steroids and close follow-up post-operatively. So these are the common early post-operative things that you deal with, but late bleb leaks are also very common. It's always better to use a stepwise approach. Use a bandage contact lens without aqueous suppression to try and stop it. Cover with broad spectrum antibiotics if necessary. A lot of things have been described, such as the use of tissue adhesives, argon laser treatment, and cryotherapy. We have a series where we had where we had bleb leaks or overfiltration, where we tried autologous conjunctival patch grafting. And what we found was most of these patients had isolated bleb leaks with or without hypotony. They had bleb leaks with or without hypotony. A few had shallow anterior chambers. And what you see over here is that if you look at this line, the postoperative pressures of all these patients actually built up significantly after surgery. So the majority did pretty well after surgery. Visual acuity also improved somewhat after surgery. So in most of these patients, in the intraocular pressure preoperative was about 4.4, it improved at 6 weeks to about 12 to 12.67. So if you have a large bleb leak postoperatively, then it is worthwhile to consider patch grafting or resuturing these blebs. Since there are a lot of postgraduates here, I'd just like to emphasize that one real emergency that you need to know how to deal with is blebitis and bleb-related endophthalmitis. And this can occur at any time after glaucoma surgery. It can occur years, even decades after glaucoma surgery. And this is the reason that any patient, any glaucoma surgeon, anybody who's had a bleb glaucoma surgery should be given instructions that in the event of a red eye or in the event of an infection, they should immediately see their ophthalmologist. So this is basically graded as mild, moderate, or severe. Mild is where the infection is limited to the bleb, but there is no anterior chamber vitreous involvement. Moderate where there is anterior chamber inflammation, but no vitreous involvement. And severe when there is basically an endophthalmitis with a bleb infection with anterior and vitreous chamber inflammation. So this is what a blebitis would present to you like. You see this sort of purulent material inside the bleb. And it's an ophthalmic emergency because this can progress very rapidly from being localized to the bleb to an endophthalmitis. You need to do a conjunctival swab, start intensive topical antibiotics, empiric fluoroquinolones and unfortified aminoglycosides are what we normally give. Careful monitoring on a minimum of a daily basis. Once it starts reaching the anterior chamber, you need to admit the patient. Add on systemic antibiotics. What we give is cephalosporins and aminoglycosides intravenously, and we need to see this patient at least twice daily to make sure that it's not getting worse. And once it reaches the vitreous cavity, then again you need topical and systemic antibiotics. You may require anti-chamber paracentesis, intravitreal antibiotics, and diagnostic and therapeutic vitrectomy. So blebitis is something that you should be aware of and you should watch for in any patient who presents like this. So this is the same patient who after 5 days of treatment, you can see there's some amount of scarring in the blood. And this is after about the 2 to 3 weeks where that entire exudation has disappeared. So patient education is very important. You should educate them not to rub their eye. You should educate them not to put water in the eye or take bath in any rivers or ponds because these are sources of infection. Aggressively treat any blepharitis or conjunctivitis in these patients and discourage the use of contact lenses. It is sometimes also recommended to use topical antibiotic administration at the first sign of any symptoms if they are away from if they have poor access to care. So post-op blood management is a very tailored approach. It requires a good rapport with the patient because you may need to do a lot of this massage, 5FUs, releasing switches, maybe putting on contact lenses. So it's always good to counsel the patients pre-op about the need for these procedures for post-op. And keep in mind that if you manage to actually work hard on your blood, those bloods will function for a long time. So don't give up in the short term and put them on anti-glaucoma medication and leave them. Keep also in mind that these bloods require lifelong follow-up. Thank you.
Another thing is, there is one quiz for postgraduate students and others. One thing
Hello.
is
Yeah.
specifically related to glaucoma, and the other one is general ophthalmology quiz. Or we can go in for step-by-step SICS approach. Okay. For the quiz, I need an assistant quiz master. Dr. Anuja, you come. One more thing. There are no fixed rules. This is done because we are one ophthalmic fraternity. Do you want to have teams on the basis of your colleges, or would you like it to be open? So you just have to raise your hands and we will pick you up like the LKG students and ask you to answer. Yeah. Okay, we'll have an open quiz. No teams. And there are certain questions which are really super questions. If you answer those super questions, we have a box full of excellent gifts. We will give it to you. So talking about that, Prasanna, get the gift bag. Quiz podunga. Yeah. நீங்க எடிட் பண்ணிட்டீங்களா?
எடிட் பண்ணுறேன்.
கூடவே இருப்பா. ஜம்ப் பண்ணி ஆன்சர் போட்டுறது.
ஸ்லைட் ஷோ போடக்கூடாது சார்.
கேர்ஃபுல்லாக இருக்கு. ஸ்லைட் ஷோ போடாதையா, ப்ரெஸ் பண்ணால் தான் வரணும். எங்கே போ ஆனால் பி கேர்ஃபுல். விடுப்பா. So, anybody can answer this question, but still, go to the symptom. Please diagnose, have a look at the boy's eyes and at the urethral opening. And one more clue, this is the X-linked syndrome. Diagnose this X-linked syndrome. Is it Lawrence-Moonbadel syndrome? Apert syndrome, Opitz syndrome, or Noonan syndrome? Before taking a guess, I mean, anyway, you're going to get the mark. Analyze everything. In Lawrence-Moon-Badel syndrome, what all features do you expect? Retinitis pigmentosa? Yes. Yes. And the ear? Hearing loss, ma? Okay. What do you expect in Opitz syndrome? Lenticonus. Here, is there any lenticonus? Make out. Okay, leave it. Noonan syndrome. Noonan syndrome. What features do you expect? I think I have got Lawrence-Moon-Badel syndrome. I can't hear you. Okay, take a guess. Go to the answer. At least now you know what all you have to go home and study. You're voting for Lawrence-Moon-Badel syndrome. Are you sure? There are so many people, all of you can choose one, sir. That is the power of mass politics. Okay. Answer. It is Opitz syndrome. Okay. And what you have to understand is it causes all problems along the midline of the body. Okay. Right. Next. Identify the drug used in thyroid eye disease. The reason for asking this question is because these drugs can also be used for other diseases. Because they also have anti-VEGF action. You are saying C, teprotumumab. You are also onto the same thing. What are the other uses of tocilizumab? COVID. It's used to prevent the cytokine storm. Answer pa, Ram. Tocilizumab. Okay, and please read this because this is more important. Right. So far, these are all easy questions, so no prizes. Plus, nobody was bold enough to get up and say, I claim this is the answer. They were all playing cautious, kirkiri beda kind of answers. Okay. Next question. No. Next session will be Kalinga Shankara. Please identify the odd one out based on the message. This is Dr. Devendra Maheshwari's talk. If you had listened properly, you will get an AirPod. Gift vandacha. C. Guessing is different. You know it. You claim it. He is saying C. Okay. C. You will go to the answer. If you explain your answer properly, you will get your gift. Answer, Papa. Yes. Oh, you explained right now. Go back to the question, drama. See, okay. First of all, what is A? Okay. And B? Hydrus, 6 mm, he told you. C? Okay, this is for uveous scleral. Cypass is suprachoroidal, uveous scleral, both are the same. Okay, and then that expensive handpiece. Okay. So what, anyway, you said that C is the odd one out. Why did you say? Yes. Answer pa. Correct. You gave the answer and you also gave the right explanation. But the reason why you gave the right answer is because Dr. Devendra Maheshwari spoke before you. So are you going to share the gift with him? One earpod for you and one for him? What shall we give, sir? You want to give this? See, I wanted to give you AirPods, but Dr. Sudip Das wants to give you the smartwatch. You wanted that? Very good. Sir, you give it to him. Please come. Which college are you from, doctor? Very good. Come. Oh. Sir, your dad opened one hospital. Same hospital. That is why you want to give a smartwatch for this. Yes. I was wondering why there was constructive interference from Dr. Das. Okay, sir. Sir, there's nothing wrong in loving your father and the hospital which he opened in Cutoff. Yes, sir. Okay, next question, pa. Identify the instrument. I'll give you a clue. Dr. Devendra Maheshwari spoke about this instrument. Okay, who's the tall boy at the last row? Get up. This is the punctum dilator. Okay. What punctum dilator? You are saying it is C. Anyway, you are from Sankara. Good attempt. Okay, better luck next time. Okay, next one. If you are talking about dilator, Tropic Plus also is dilator. That's good. Okay, name the clinical condition named after objects shown in the following pictures. Now, this is a slightly tricky question because you see one mountain and you know the name of the mountain. But the name of the mountain is not the name of the disease. It is the name of the study associated with the disease. Yes, ma. You are saying it is diabetic retinopathy. Why? Very good. Which hill study? Like Kodaikanal Hill or Everest? You are halfway through, half the airport. But she guessed it right. Hill study. If there is hill study, there should be some other study, ma, based on that mountain. Good. So what is Everest study related to? What is hill study related to? But I am happy you are thinking along the right track. Answer. Okay? Right. Why? Why are you wrong? If you understand why you are wrong, you will be correct the next time. Please read. Okay, and the reason for showing that Saturn is because it is a planet. So you caught the hill and Everest, but you forgot the planet. Right. So any expert opinions from the panel? Okay, next one. Once again, in addition to knowing the answer, you should also know the diagnostics behind it. Please identify the personality with the help of the clue. Okay, group answer. Does not matter. That is why we are not here to hand over gifts like Biju Kalyan Yojana for everybody. That only your chief minister will do. Anyways, trachware, you were all here yesterday. Dr. Vasu spoke about trachware. What did he say? This is not a quiz question, but just he spoke about trachea. What did he say? Yes, yes. It is a hill of vision surrounded by a sea of darkness. That was told by Henry Trachea. Next question. Should we do this or shall we skip it? Strabismus. Okay, identify the transposition procedure. Madam? Good. You are saying it is Jensen procedure. First of all, you tell me what the procedure is. See, lateral rectus is weak. So they have split the superior rectus and inferior rectus and strengthened lateral rectus action. Some sixth nerve abnormality. Now you say it is Jensen procedure. What, doctor? Which college do you belong to? Good. It is the Hummel-Shame procedure. Anyway, congratulations, doctor. First of all, you should be bold to answer and to stand by it. Anyway, next. Postgraduates, you have no excuse. Whoever reads Payman Volume 3 must be able to answer this. Yes, ma. Your answer is optic neuritis. Okay, doctor, you introduce yourself. In Sankara. Okay. Any other answer contrary to this? She says it is optic neuritis. Yes, ma. Be bold. Oh, you lifted your head only to touch your head. Okay. Yes. Okay. All related to optic neuritis. Saripa. It is optic neuritis. Good. Very good. But because you belong to Sankara Eye Hospital, no gift for you. Next. Next. Which of the following studies aim to compare the visual outcome and adverse effect of contact lens to primary intraocular lens correction of what, ma? What is IAT study? Yeah? Infantile aphakic treatment study. Okay, what is pedic study? No, I'm just asking. It's the wrong answer, but tell me. What is that other study? I ate oats study. Okay, answer. Very good. So where are you from, doctor? We'll give her a gift, sir. Yes. Dr. Maheshwari, you hand over the gift to her. No, no. Sir, you come. You be with us. Congratulations. Keep answering. Next part. Which of the following structures are not passing through foramen ovale? Yes, ma. Yes. Huh? Okay. Wait. Middle, you said accessory meningeal nerve, B. Okay, now I ask you, which of the following structures are not passing through foramen ovale? You said it is accessory meningeal nerve. Okay. What all passes through foramen ovale? It is an acronym. What passes through foramen ovale? You're the right person. Correct. What passes through foramen ovale? Aortic ganglion, mandibular division of the fifth nerve, accessory meningeal nerve, lesser petrosal nerve, emissary vein. You said emissary vein. Anuja, you said emissary vein. Okay, does not matter. This lady gave the correct answer. Please get up. Come here. Which college are you from? Burla Medical College. Okay. Sir. Okay. Sir, we'll ask our Air Force man, Mr. Aurobindo Mohanty, to hand over the gift. Ladies and gentlemen, Sir is from the Air Force and he was a gazetted Air Commodore. Yeah, he's very serious about all this and he has to be. The Air Commodore, Aurobindo Mohanty. Yes. VSM also. Vishishta Seva Medal. And more than that, he was the former CEO of Sankara Eye Hospital. And the previous two Kalinga Shankaras, which Dr. Das had conducted, it was very successful because of the efforts put in by Mr. and Mrs. Aurobindo Mohanty. Sir, you can hand over the gift. Come. This one. Sir, you come. Sir. Next question, Ramo. So remember, before saying this does not enter, that does not enter, first find out what enters the foramen ovale. Okay, which of the following is false about Steiker test? First of all, what is Steiker test? First get that into your head and then start guessing. Optometrists, you should know Steiker test. If not, I think they should contribute 50 rupees for not answering this question. You are free to guess, there is no problem. But what is Steiker test? That is short notes. What is Steiker test? You are right. It consists of both alphabets and pictures. It consists of only toys and eatables. All of that is right. But first of all, what is Steiker test? Read it. He said, okay, come. Dr. Das has positively interceded on behalf. Screening test for young children and retarded. Come. Sir, you give the prize to him. We have given him a wallet with a RFID because he is very forgetful. So he does not know where he has kept his purse. Using his cell phone, he can find out where his purse is. He can't. Where are you from?
I am from MKCG Medical College, Berhampur.
Very good, very good. So MKCG is your dad's college. Okay. Once again, MKCG, I still don't know what it stands for, like Steiker. MKCG Medical College was started in Berhampur with the initiative of the late Biju Patnaik and Sir's dad, not, okay, the king. Okay, so that medical college was started by the king's donation, and the first person who took over the responsibility as the dean of the medical college was the late Dr. Sukumar Das, yes, who is Dr. Sudeep Das's father. Okay. Anyway, it was started by Dr. Das's dad. So that boy who got the prize, thank your stars, you are from Berhampur. Maharaja Krishna Chandra Gajapati. Good. Next one. Staring, this is a very beautiful question. I want you to concentrate on this. and this is psychological. Done. It's a beautiful question, and this is used by the Indian Army, the spying agency, and the cheetah which attacks the prey, and the gazelle or impala's child. Discovery Channel. Staring at a fixed point for an extended period of time would cause the peripheral areas of the image to fade away. This is known as Broca-Sulzer effect, Troxler effect, Purkinje effect, Donder effect. Yes, ma'am. You want to say it's Broca-Sulzer. If you say it is Broca-Sulzer, then you should know why you told Broca-Sulzer. Now you tell me what is Troxler effect. First of all, you should understand this effect. You have the impalas and the wild beasts, etc., which give birth to their young ones when they are migrating from across the Serengeti. While doing so, they deliver their children. At that time, you have several cheetahs, lions, and hyenas. Forget the hyenas, they will find out everybody. The cheetah fixes its target on one particular animal and then it starts running towards it. But what happens is, if the child which is born keeps quiet, does not move, does not shake a part of its body, then as the cheetah keeps running towards it, it fades away. So it is a protective mechanism of the gazelles and the wild beast children to just keep quiet when there is an attack, and the cheetah will ignore it and go attack the moving target. And one more reason why the cheetah or the lions are not able to get this newborn is because it has still not passed urine, so it does not have its own smell, whereas the other animals have their own signature smells. So it is a protective mechanism adopted by the gazelles, etc. That is why it is very important among the animals. And among human beings, these snipers, what they do is they will shoot, and even if they get caught, that is somebody has identified, they will not move. They will just stay there in the spot, so that they are not identified. Answer. Okay, so this is known as the Troxler fading effect, and it was discovered by the Swiss physician and philosopher. Please understand, the most important thing about this question is the philosophy behind it. If you want to exist in a hostile environment, keep quiet. Keep quiet. Don't present any antigens for any antibody reaction. Just keep quiet. You will survive. Okay, so that's the philosophy behind it. It does not matter that you do not get the right answer, but this is the fact. Right. The corneal epithelium contains all of the following: Langerhans cells, wing epithelial cells, basal epithelial cells, dendritic cells, except one. Yes, ma? Dendritic cell. What is your name? Where are you from? MKCG, Berhampur. Gift guaranteed. Come. Answer, Katupam. Dendritic cells is the correct answer. Very good. Come, doctor. Sir, we will request your dad's student to give the prize. Come, sir. What shall we gift her? She is from Berhampur. Sir, please come. You should understand that sir is Dr. Sudeep dad's. So please come. Very good. Appa, switch on all the lights. Yeah. Amma, because this is a very beautiful answer. Very good answer. Sir, you give the gift. Sir, you stand next to your father's student. Very good. And there is a reason behind it. I told you Mullah Nasruddin's story. Before you go and light lamps in the mosque, you first light lamp in your house. So before we go out and start encouraging students from other states, We will first encourage students from our state. Next one. Okay, this is the whole forming factor. I don't expect you to answer it, but please understand that such a thing exists. These are all trick questions which we use to demolish the ego of some of those smart fellows. Go to the answer. Pa. This is about the macular hole, OCT picture. You know, pa? You had it in your throat. Okay. Oh, you knew the answer. What's your name, doctor? Okay, forget it. Now you tell me why this hole forming factor is important. You gave the correct answer in your mind. I was not able to listen to your mind voice. So you tell us, why is this important? Sorry, Udupa.
The success rate of macular hole surgery depends upon the base and the width of the hole.
You knew the answer. Why did you keep quiet? Already you could have come forward. Next question. Okay. Identify the odd one out. What is the first picture about? And then C. A, B, yeah, sorry. A, B, C and D. Yes. This is B. Yes. Go to the answer. Exactly. Now, what is Kestenbaum's number? One person get up and answer. Yes. Kestenbaum's number. You know, ma? Yes. What is the relevance of that number? Papillitis, papilledema. Right. Okay. Righto. Which of the following does not apply to fluorescein? Which is not the answer? Okay. Before going to that answer, you tell me what is the difference between fluorescence, phosphorescence and effervescence? Should the light source be active at that time, or is it in the absence of light? Okay, you have a watch with radium on it. What is that? Is it fluorescence or phosphorescence? That is phosphorescence. Now we are talking about what does not apply to fluorescence. It's not a straightforward answer. Okay, what do you want to say? What is your answer? A is your answer. Good. Popa. A is the answer. Correct. But the take home message for you is, please understand the difference between fluorescence, phosphorescence and effervescence. Right. Gift should be gift. She's already received a gift. She's got one already. Yeah. Next part. Okay, this is one of those case studies. A 59-year-old male patient presents with a 10-year history of gradual, painless loss of vision. Vague history of ocular trauma 10 years ago. Probable diagnosis. Let it be, ma. It's okay. Picture quality is like that. You want to say it's C. That boy also wants to. Salesman. B. You want to say it's band-shaped keratopathy. Salesman. Okay. Salesman. Which college are you from? JPM Rotary. Okay, come. Where is our man? Sir, Vanga. Mr. Vishwanathan, sir. You give the gift. Vanga. Sir, why have you put an eye drape? That's also a gift. It's also a wallet. I thought it was eye drape. Okay. Oh, you're a Rotarian. Okay. Next question, pa. Innu 3 questions. We'll finish shortly. I think our man is feeling. Huh? Okay. Sir, if you want, I have 20 more questions. Or shall we finish with this? Okay. Appa Saripa. Come to this histopathological finding. Thank you, sir. Who said C? Correct. But you have to explain. Yes, green. What's your name, doctor? Pradyumna. Please explain. Yes. And in the first picture? Give him the clue. What's the answer? The broken arrow sign, the tadpole sign, and then what you said as muscle fibers are actually cross striations. They are not muscle. Okay. Anyway, rhabdomyosarcoma is the correct answer. But because you needed help from all quarters, we will congratulate you and ask you to take part in the next question. Right. Good. But correct answer. The most common cause of contact lens induced. Two of you. You get up. Yes, doctor, you. And you, madam, you get up. You both are revealing the same answer. What is your answer, sir? You say it is. You changed your mind now. Sir. You, ma. You're saying it is acanthamoeba. Pseudomonas. Answer, pa. But because this was a collective effort, your gift will be served during lunch. So shall we conclude with this? Okay, on a very happy note, let us conclude. There is one more gift left. Adutha question. A patient with Kearns-Sayre syndrome has all of the following except you have to say C, anterior hypopituitarism. That's your answer. You? C. Okay. I ask you one thing. Where is hypopituitarism found? Okay. Have you heard of the Turkish saddle? What does a Turkish saddle look like? Sella turcica syndrome. Okay, there's a small history behind the Turkish saddle. In the past, many people were conquering various parts of the world. Those who were able to do it very well were those who could ride horses properly. So you had people like Genghis Khan, etc., doing it. But Genghis Khan and others could ride barebacked horses. They wouldn't even have a saddle. They'll just put a leather piece and they will cut the horse meat, put the meat between the leather piece and the horse, and in the friction it will get partially cooked. They will eat that meat and keep traveling and conquer various parts of the world. That was the Mongol style. Then you had Timur, who was a Turkish guy. He was a much more comfortable horse rider. So what he did was, he created a saddle in which there were 2 fossa for the rear and 2 fossa anteriorly for the thighs. So these riders could comfortably sit on that saddle and travel throughout the night. So that is why it was known as the Turkish saddle. And that is found in the pituitary gland in the sella turcica or the empty sella turcica syndrome, which is post. Exactly. So that is why it is known as the empty sella turcica syndrome. Anyways, answer pa. Okay. It does not matter. At least you came to know about Turkish horses, Genghis Khan, Timur and other people. Next. Which immunoglobulin is absent in tears? IgM, 2 boys. You both get. Oh, you are in alliance with him. Okay. Okay, you stand. Because your alliance partner wants you to be the chief minister candidate. So what is your answer? IgM. What you wanted to say IgD, then why didn't you say? Okay. Right, pa. So understand IgD is not present in tears. Next. All of the following are poor prognostic indicators of uveal melanoma, except, this is once again a trick question for B, epithelioid cell type. That's your answer? Okay. It does not matter. Come. This is not for human beings. Next question. This is a nice question. Picture perfect. What? Who said Alport syndrome? Okay, thank you. You? Peters anomaly. That's your answer? Who said C? You. What are you doing? You're a consultant. Okay. Answer. So that is why I wanted to know who you were. Because you can easily fall for the trap. Go back. Go back. All of the diseases are linked with this condition. What is this condition first of all? Of? Correct. Is it only anterior? Microspherophakia and then fetus. Amma, you remove your mask and talk. There is no more corona. Okay. Anyways, the answer is sulfate oxidase deficiency, because there will be dislocated lens, but there will be no microspherophakia. Okay, should we give to? Okay, okay. Let us call our PRO and Mr. Babu. Please, both of you come, because whether you are a consultant or not, you have answered correctly. Therefore, and you are a glaucoma consultant. So we will give you the gift. Please come, sir. Sir, come. This is Mr. Srinivasan. He is a PRO This is Mr. Babu. He is a present CEO. Ninga kudunga. Thank you. Congratulations, doctor. So, my dear friends, I still have many more questions. But Dr. Das is aware that I like eating and drinking. And I told Dr. Das, when the food is very good, when the taste is excellent, when the satisfaction is at its peak, you should stop eating. If you go beyond that, it will come out from the wrong end. Similarly, a good event must come to its conclusion when everybody is happy and we have attained our objectives. I have a humble feeling that we have reached that point. Therefore, I will stop here and thank all of you for having been so cooperative with us and for having made this function a grand success. Now, I shall hand over the mic to my junior most colleague, Mr. Vishwanathan.
Thank you very much. All of you were very happy, hectic right from the morning. Sankara Eye Hospital and Samarjhola was started with the blessings of His Holiness Shankaracharya of Kanchi Kamakuti Peetam, supported by Government of Orissa, headed by Srijukta Naveen Patnaik, our Honorable Chief Minister. You can give us a clap for him. And in a great distress period, with the continued support of Dr. Sudeep Das, that is very important. And today's function was a very grand success with the support of all our staff. They have involved here and done wonderful thing. All of you have come from different places. We are extremely thankful to you, having attended the function, and probably all must have been delighted. Dr. Sudeep Das has got a dream. Abdul Kalam's birthday was there 1 or 2 days before. He used to say dream, but implemented the dream. So he is a person who is dreaming to implement a lot of dreams. Now after this workshop, when this was organized, he was overwhelmed. And he has suggested that every 3 months or 4 months we must have one workshop here at CME for various subjects, cornea, retina, oculoplasty, or whatever in eye care, eye department. We are confident we will be able to go through, and all of you, we welcome you to participate every time when we organize. We will take care of you. Thank you very much. Now let me just honor few of our dignitaries here.
And here's a small note for all the postgraduate students here, because you have the ability to do one thing. Dr. Ramu Siddharth's dad, Dr. Ravichandran, had completed 5,50,000 plus cataract surgeries in his lifetime. 5,50,000. He was in Arvind Eye Hospital, and then he started his own Ramana Maharishi Eye Hospital in Tiruvannamalai. 5,50,000, not by the institution, by one individual. It was done by the late Dr. Ravichandran. So, dear PGs, you have a role model. You can do this.
I started my surgery. time when we were doing ECCs then in Arvind, and I would start an ECC and I would see the vitreous, and I was getting really depressed. And then I went to his dad crying. He said, "What? I can't do this." The thing is, before that I had done ECCs during my PG days, and I had never seen an ICC before. And these are like naked eye surgeries. I had never done anything naked eye. It was all through microscopes. Then he said, "Don't worry, Sudeep, I'll stand with you." So next day, this total unheard of sight. The junior most fellow, the bacha in Arvind, me, with this second most senior most fellow, and the sister saying, "What? How is this happening? How is he standing next to him?" He didn't do anything. He just stood next to me, and everything went well. And just things improved wonderfully after that. And he always told me that I will send Ramu to learn Peko from you. And he was such a wonderful surgeon. But wherever I was, it doesn't matter where you are. I was then in Bangalore, and then I came here. He actually sent him here.
Oh, I am doing surgery because of sir.
Dr. Dad was telling, I was also surprised. Rather, it took my olden days. I was thinking, when we started Sankara Eye Hospital in Chennai, I know the doctors were doing surgery with a loop. I don't know, none of you would have seen that loop also, I think. Have they kept in an exhibition in your colleges? So, subsequently, with all these microscopes, so many improvements, phaco. Now nobody knows even SICS. Now everybody goes to phaco directly, what I understand. So that is the day now. Very nice. We have passed through very good days. Let me invite Dr. K.C. Padi. Dr. K.C. Padi, one of the senior most person and well-wisher of Dr. Das. So we are all with Dr. Das. So we are also in your team.
It's always such an honor, such a senior person. He's always
I'm surprised to see any glaucoma workshop. Conventional discussions were there. Here I learned something beyond it. Yesterday and today. I'm so happy about it. And thanks to you.
All of you have seen Dr. Das, Sudeep Das, a veteran. And the blessings of His Holiness, Dr. Das also joined us in our team, did wonderful work taking forward. As I told you, people will be looking forward for further CMEs and participate in that, get better and more knowledge. So we like to honor, even though he is our own team, still he is our head. Head should be very comfortable. We pray the Almighty to give him enough strength, good health and good life. Thank you. We will be distributing the certificates to all the participants, particularly the PGs and other delegates who have come here, medical fraternity. All of you enjoyed the session. But for Dr. Muhammad Sai, it would not have been so much a happy mood here. So I want every one of you to congratulate or clap for Dr. Sai. Yeah. All of you know Sai is always an encyclopedia. Let me invite Air Commodore Aravind Mahanti, our ex-CEO, who has been kind enough to participate in this program today.
Air Commodore Aurobindo Mohanty is a very unique being. What? Because when we first organized the Kalinga Shankara in 2019, at that time no academic event had been organized here in this institution. So from the Rangoli Kolam to the flower pots, arrangement, decoration, certificates, organizing of speakers, all of these things were done by Dr. Sudeep Das with the help of Mr. Aurobindo Mohanty. So I am really grateful to Mr. Mohanty for being the best supporting CEO. Congratulations, sir.
And he was basically in logistics in the airport, so it really helps in any other institution, logistics.
Definitely. Okay.
From the first brick, I've been here 2015 and left only in April. And it has been a fantastic journey. When Mr. Vishwanathan and his son-in-law called me up, I was doing some solar work in Leh. And they said, we're opening an eye hospital. I said, I've never even reported sick during my service career of 34 years. I don't even know what's paracetamol. I just can't run a hospital. They said, don't worry. We will run it for you. You just say yes. And the journey has been so beautiful, and it has been such a pride to be with you all, especially the children. They're taken from all over this countryside without any knowledge of medicine, any knowledge whatsoever. And the job they have done, you can see it for yourself. Phenomenal growth, and it has been a great journey. Of course, leaders have been many. The hospital has really done one. Many of us, then we took on. And you see the result, and this is the culmination, and all of you, I'm sure you have enjoyed and you will remember. Thank you, sir, for the great honor.
Sir, आप रहिए, सबको सर्टिफिकेट देना, आप भी रहिए।
Dr. Subhash Chandra Paliga. Patra. Sir. Sir. Dr. Rajesh Kumar Sethi. Dr. Rajesh. Come. Dr. Pooja Patnaik. She answered quite a few questions also. Dr. Shaswati Sen. Oh, you are Dr. Shaswati. Welcome, Doctor. Dr. Shaswati Sen, come and have a pen. Yeah. Dr. Pravalika Pamulopati. Is it that? Correct, Danamma? Pamulo Padi, not Pati. Okay. Padi, Padi. I am from Tamil Nadu, so my pronunciation will be slightly different. Like Italy, Sambar. Dr. Shefali Asif. Amma. Why don't you all have easy Tamil names? Oh, here. Please. Dr. NVR Rao. So what is this NVR, sir? What is NVR? Nyayapati Venkata Raghunatha Rao. Very good, sir. Yarlagatta PVR Narasimha Rao. Yeah. Dr. Soumya Ranjan Panda. Oh, very good. Sir, there was another Dr. Ramarao. He's there. Dr. Gayatri Devi Palo. Dr. Avik Roy. Oh, sulfate. Sulfate oxidase deficiency. Okay. Dr. Satyabrata Jana. He did some group answering. Dr. Banaja Singh. You can come with a baby. Dr. Banaja Singh was here with us during the first Kalinga Shankara, second Kalinga Shankara. Now she has started her own hospital in Koraput. So all the best, doctor. Dr. Nageshwar Patra. Dr. Nageshwar Patra. He was here. Okay, he'll be outside. Yeah. Dr. Amit Bidha Sangiya. Okay. Who is this calligraphy writer, sir? Nalini. Oh boy. His English is looking like Odia to me. Where's Nalini? Just because you like Odia, you will write English like Odia? But he was the man who sang Utkala Janani. Mr. Dr. Niranjan Jana. Dr. Bidisha Mahapatra. She gave a wonderful presentation yesterday, how we diagnose glaucoma. Dr. Sita Mani. Dr. Anuja Mohanty. She answered quite well, but because she was our staff, we did not give her any prize. Dr. Smriti Lekha Sahu. Yes. Amma, you should look at your spelling. It looks like inscription on Kandagiri. Brahmi, Prakriti, Pali. That script. Dr. Vijay Kumar Mishra. Welcome, sir. Dr. Yamijala Neha Srija. Dr. Dega Panisha. Dr. Dega. Oh, you're Hanisha. Okay. He has put two tentacles of the crab. Dr. Vijay Kumar Naik. Dr. Vijay Kumar Panik. Okay, he's outside. Yeah. Naik. Dr. Suprava Das. Oh, is she related to you? Das. Amma, is it correct? Dr. Suprava Das. Very good, very good. Dr. Chantala Navya Shri. Very good. She attempted quite a few questions. She answered well too. Congratulations, doctor. Dr. Shreya Chakraborty. Dr. Shubhashri Prushti. Berhampur. Dr. Somani Banyal. Or is it Bangle? Dr. Somani. Dr. Somani Baral. Please don't think that I have some refractive error or astigmatism. It's because of this Nalini fellow's fonts. Dr. Raghu. This is so simple. Welcome, Raghu. Good. Dr. Samir Dash. Is he related to Hagen Dash ice cream by any chance? Samir Dash. Dr. Soumya Kanta Mohanty. Welcome, sir. Dr. Syed Ejaz Hussain. Dr. Anjali Goyal. Do you sing well? Okay. Goyal, yeah. Goyal. Dr. Soumya Ranjan Patra.
Oh, I get it. In Tamil Nadu, Goel will become Goel.
Come, doctor. Dr. Pradyumna Mishra. Come. Yes, sir. Dr. Anjali Biswal. Arati Biswal. Very good, doctor. You attempted several questions. Good. Dr. Soumi Roy. Soumi Roy. Soumi Roy. Idu pata chuma. Have we forgotten anybody? Yes. Have I forgotten any postgraduate students? No. Okay. Now we call upon the representatives of the Appasamy Associates. Certificates. Mr. Vijay Kumar, please come. Dr. Bharat, Mr. Bharat Appaswamy. Vapa. Ah, Bharat. Irukku sir. All memories are beautiful, but we need reminders for those memories. Therefore, I request you all to go straight to the photography session before going for lunch. Yes. First, we will go for the photography session and then go for lunch. I request all of you. Yes. We will lead you all right now.